Assalamualaikum and good evening. Welcome you all to our Gynae Onco Imaging Series. It is a joint initiative of the Oncology Club Bangladesh and Tata Memorial Hospital, Mumbai. All we know about the Tata Memorial Oncology Club Bangladesh and also the Tata Memorial Hospital. We have discussed about these two organization, and today we'll directly go to our session. Today, our second day of this session. Today we'll discuss on the ovarian malignancy and all about the anatomy of the imaging of the ultrasound, CT, MRI, and also the introduction of the lexicon and the ORATs, and also the peditherapy assessments of the diseases burden of the accessibility of the criteria for the planning cytoreductive surgery, and also we have the panel discussion. And all the eminent radiologists from India are involved in our this gynae onco imaging session. And some of our eminent gynae oncologists, the medical oncologists, radiation oncologists, all are involved in this program. And all we know the imaging, the importance of imaging in gynae oncology. So we have tried to make the session, though we could not elaborately describe it, but within these three days, we tried to cover all the parts of this gynecological malignancy. Our inspirator to this are with our scientific secretary, Dr. F.M. Kamaluddin, our General Secretary, Dr. Professor M. Shariful Alam, and Professor M.A. Haisar, who is the president of the Oncology Club. We would like to ending this program, starting the session, we at first we'd like to invite you all to attend our Bangladesh International Cancer Congress 2022, which will be held in 17 to 18 November in RP Golf Club, Dhaka. And we have invited around 30 international faculties. And although we are not in together, but words can be like the X-ray. If you use them properly, then they will go through anything. You read and you are the buyers. So I think this is the end of the introductory session. Today with me, the total session, it will be conducted by our gynae oncology, the fellow, Dr. Rumana Afroz. She will conduct the rest of the session. So I would like to introduce Dr. Rumana Afroz. She is the fellow in gynae oncology, and also she is fellow in obstetric and gynecology. Over to you, Rumana, please.
Thank you, madam. Am I audible, madam?
Yeah.
Welcome everyone to second day of gynae oncology, gynae onco imaging session. Today is the second day. Can I share my slide, madam?
Sure.
In second day, in first session, we have three presentations that will be delivered by three eminent radiology and imaging specialists. In second session, there will be panel discussion session. In first session, our first presenter is Dr. Ekta Dhamji. She is additional professor, radiodiagnosis, BRA, IRCH, and she was senior resident 2011 to 2014 AIMS New Delhi and research fellow in 2014 IIT New Delhi. Her special interest is on oncoradiology. Today, her topic is imaging of ultrasonogram, CT, MRI, anatomy of ovaries. I'm requesting our participants to put their questions on chat box if they have any queries. I'm requesting Dr. Ekta Dhamji, madam, to start her presentation, please.
Speak about ovary, it is never an organ in person. We have to consider that it is part of adnexa, the term which we use frequently. And adnexa refers to ovaries, fallopian tubes, and the surrounding ligament in context to the female pelvis. So basic anatomy of ovary, we all have read throughout our MBBS side that it is just an ovoid, almond-shaped structures. But the important point to note is that it varies in size depending on the age, hormonal status, stage of the menstrual cycles, with a mean volume of 3 ml before menarche 10 ml in menstruating females, and postmenopausal up to 6 ml is acceptable. The important thing about ovary is that it is a loose structure. It is a very important organ, but it is not a fixed structure like liver and spleen. It is anchored in the true pelvis and pelvic peritoneal cavity by three major structures, that is mesoovarian, uterovarian ligament or suspensory ligament, which are responsible for holding it in place and for its vascular and lymphatic drainage. So it becomes important for us to understand. Now, these are not the anatomical structures which are static. So we need to understand from where they all came. So it was basically in week 5 when embryology starts and the genital ridge, gonadal ridge is formed. These primordial germ cells start migrating into the gonadal ridge, and gradually these mesonephric ducts and mesonephric tubules, they start developing, and paramesonephric duct separates. So I'm not going into detail of all this. It is just a brief thing to know that finally there is a cortex formation, there is tunica albuginea, and all those germ cells, they go and form oogonias or the primordial follicles, which are responsible for the function of the ovaries. The rest of the structures, they involute all these mesonephros or the ducts, and they form what we call as mesoovarium to hold it in the position. So this is just the basic and very brief overview of how ovary is placed or how ovary develops, and which we should know before directly jumping into the anatomical or structural characteristics. So it is an important part for us to understand that the cortex is what, because the imaging will be exactly what was embryology. Now, these are the beautiful pictorial representations in one of the radiographic article, which I would always recommend to read. It is basically that the ovary lies in the ovarian fossa on the lateral pelvic wall side, and it is enveloped by the fallopian tube, as we can see, and it is surrounded. The ovarian fossa has landmarks of ovarian vein and artery, which are passing through the suspensory ligaments. Posteriorly, there are ureter, inferiorly uterus, then the round ligament, and quite laterally is the external iliac veins. And the important thing is that this mesoovarium, which we understood in embryology, is the peritoneal fold basically. And this is what anchors this ovary into the broad ligament, which is another peritoneal fold, which holds the uterus together and attaches it to the pelvic walls. So all this goes back to where the ovary had developed. And that is why it is important. We always considered ovary. Good evening, everyone. Let us start with the first topic for today, that is imaging anatomy of ovary. Before directly going to the ovary, I would like to introduce the term adnexa and try to make it familiar with everyone. The important thing about this is that whenever we talk about adnexa, we are trying to refer to an appendage of an organ. That means we are not defining a distinct anatomical structure. However, we are supposed to be familiar with the anatomical structures separately as well. So when we say adnexa, it encompasses ovaries, fallopian tubes, and all the surrounding ligaments which it comprise or which are constituted or as a part of female pelvis. So whenever we try to say that there is anything in the adnexa, we are trying to tell that we don't know the specific site of origin. It can be ovary, it can be fallopian tube, it can be the ligaments, it can be the mesenchyma, and all in all, they tend to engulf each other. So that is why the term per se has been replaced and most commonly used as adnexal pathologies. So now, since the topic today, we are focusing on the ovary. We know we have known this since the time of our MBBS. This is just theoretical, that it is an oval, soft, almond-shaped structure which vary in size depending upon the age, the hormonal status, or the menstrual cycle, with the mean volume of 3 ml before menarche, 10 ml up in the menstruating females, and 6 ml in postmenopausal females. What is important when we talk about ovary is the ligaments which engulf or which suspend or which anchor it to the pelvic structures or the pelvic walls, because ovary per se is a very loose structures. That is why we often tend to first rule out ovarian torsion whenever patient or female presents with acute pelvic pain. So the anchoring structures include mesoovarium, uteroovarian or ovarian ligament, and the suspensory ligament. We'll see subsequently how they look and what is their role. But first, to understand, going deeper into the imaging or cross-sectional anatomy, we need to have a basic just overview, not going into the detail about the embryology. That it starts at week 5, then that embryo has a gonadal ridge, and later on all these primordial germ cells, they migrate into this genital ridge. The mesonephric tubules, they undergo degeneration, and what at the end we get is that we have an ovary with the cortex, with the tunica albuginea. All these germ cells have then further classified or further formed into the primordial follicles, or what we call as oogonias, which are responsible for the menstrual cycles and the follicular cell development. The rest of the structures, that is these mesonephros and mesonephric ducts, they all undergo degeneration, but it stays, this recte ovary, it stays here as a meso-ovarium, or the suspension or the anchoring part. So this is how we get the female ovaries get developed, and these are the relationships with the surrounding structures, which translate to what we see in the ultrasound, CT and MR. What is the basic thing to understand is to get a hang of what basically the function of ovary is and what are the ligaments, because that is how we will be able to differentiate if the mass or the pathology particular is within the ovary, or it is an adnexal pathology altogether. And if it is an adnexal pathology, whether it is ovarian, that is peritoneal, or the extraperitoneal. So all this revolves around the basic anatomical structure. So let us just start with this beautiful diagrammatic representations in an article in Radiographics, that is a must read, which shows that the ovary lies in an ovarian fossa of the pelvis, in the lateral pelvic wall, in the true pelvis, and it is bounded by ovarian vein artery suspensory ligament cranially, posteriorly by the ureter, inferiorly by the uterus, anteriorly and laterally by the iliac veins, engulfed and enveloped by the fallopian tube, and inferomedially is the round ligament, or the part of broad ligament. This entire shaded area is the meso-ovarium, which suspends the ovary and connects it to the broad ligament, which is another peritoneal reflections, which suspends uterus and connects uterus to the lateral pelvic wall. So all these ligaments are just the peritoneal reflections, but they get thickened in certain areas to get structures attached to each other. Suspensory ligament is what is responsible for the drainage and the arterial supply to the ovaries. Fallopian tube lies in very close relationship, and that is one of the reasons that the ovarian malignancies have been now called as the tubo-ovarian malignancies, because it has been shown that even the tubal cells can undergo metaplasia and can give rise to epithelial ovarian malignancies. So just for another representation, that this is a suspensory ligament which supplies the ovarian vessels, fallopian tube, ovary in the ovarian fossa, suspended, connected to the uterus by the uterovarian ligament, and this posteriorly is the ureter, this externally iliac vessels going quite laterally, round ligament quite anteriorly. Now, when we see in the cross section on the CT or MR, it will not be like exactly like this. So slight reformation, and this is how it looks, that this is the uterus and this is utero-ovarian ligament, this is the fallopian tube enveloping the ovary. The suspensory ligament will be seen something like this rather than coming from the top, because this is the axial section, and this is the ureter which goes posterior to the ovaries, and round ligament, it goes anterior towards the pelvic walls. If we try to replicate the same on the cross-sectional, this is the uterus, this is the utero-ovarian ligament, this is the large left adnexal mass, this is a suspensory ligament with multiple vessels, because all the vessels are either supplying or draining. This is the ureter coursing, posteriorly to the mass, and all these are the draining vessels. On the right side, what we see is that this soft tissue is the round ligament going anteriorly. This is the ovary. This is because it is in direct relationship, there is no ascites, it is difficult at times to delineate the ligaments separately. In the presence of ascites, it becomes very easy. So whenever we talk about any particular organ or its anatomical relation, it becomes imperative for us to understand that it has an arterial supply, it has a venous drainage. So ovarian artery gets arises from the aorta directly just below the level of the renal artery. It courses along the ovarian veins and into the suspensory ligament. It goes cranially and supplies the ovary. Ovarian veins basically form the tympaniform plexus within the mesoovarium and then form one of the major draining veins, and then they drain directly into the ovarian vein, which goes to the left renal fossa on the left side, left renal vein on the left side, and the right ovarian vein drains directly into the IVC. So that is what we have to look. So basically, it doesn't look that complicated, but because structures are so closely related to each other, that it becomes important for us to understand these anatomical landmarks so that we know when we are doing a radiograph or ultrasound or MR or CT as to what we are looking for. So whenever we talk about radiograph in terms of adnexa or uterus or the female pelvis, we are trying to refer to HSG, hysterosalpingography. So it becomes important for us to know here itself that it is not to evaluate ovary, it is basically for the tubal patency. So we are not going into detail with that. We'll start with what all modalities are used for evaluation of any adnexal masses. It is basically the TVS with Doppler because it has a very good sensitivity and specificity, and it stays as the first imaging modality for any evaluation or characterization of the lesions, followed by CT first to see the disease extent once we are suspecting malignancies, and MRI basically in indeterminate masses and N as a problem solving tool. PET for characterization of adnexal masses has very poor sensitivity and specificity, because whenever we try to evaluate adnexal pathology, we want to first determine whether first there is any pathology. And if there is a pathology, either it is benign or malignant. And if it is malignant, what kind of surgery can be done for the patient? And if the patient is post-op, it is used for surveillance. So TVS with TAS remains the primary modality for identifying and characterizing. So it is the first stop shop for the patients because it is available, yes, but it is very good for delineation, the characterization of the masses. The patient tolerates them well, it is cost effective. What to do when the patient is unmarried or has not had intercourse or the hymen is still intact? We can do transrectal ultrasonography in those females. But all this is always accompanied by TAS because transabdominal ultrasound on full bladder gives a wholesome idea about where the uterus is, where the ovaries are, because ovaries are loose ligaments. They can be lateral, they can be just adjacent to the uterus, they can be quite far away from the uterus depending on how much extension of the mesoovarium is, how much is the broad ligament, where all the ligaments are anchoring it. At times they're quite lateral towards the lateral pelvic wall, but that is what is anatomy and that is what is expected. It is not abnormal, especially in postpartum females or in pregnancy, because uterus pushes the ovaries quite high up in the abdomen. So transabdominal ultrasound gives us a basic idea of what we are dealing with and if TVS will help at all or not, because TVS will help only if there is an adnexal mass and to characterize it. But if it is high up, if it is a large mass, TVS is not going to help us. So TVS and TAS becomes the first stop, first imaging modality. Then comes MRI. MRI is basically on ultrasound if it is an indeterminate mass, or we are trying to evaluate whether it is endometriosis, what is the relationship with the surrounding structures because we are contemplating cystectomy or something like that. So local invasion is very good because of its excellent contrast resolution. CT is the mainstay in the setting of preoperative for proven or known or high index of suspicion for ovarian malignancy, but not in characterization of the adnexal or ovarian mass. Similarly, for PET, its role is highly valuable in detection of recurrence. So now commencing on basically how the anatomy or how the ovary functions, because its anatomy varies with menstrual cycle, right? So we cannot have a static anatomy like liver or spleen that there are segments and that is how we have to look. But because it varies, there is a variation. How there are variations, that these primordial follicles, which we understood in embryology, they form a pre-ovulatory follicle during the menstrual cycle up to the day 14 on an average, which undergoes ovulation and ejection from the outside the ovarian stroma, and they are captured by the fimbriae of the tubes, and the residual is what is seen as a corpus luteal cyst, which later on degenerates to form corpus albicans. So this is what we all know that the menstrual cycle goes through. But how does it look on ultrasound? So basically it starts from the left side. It starts that the ovary is there, very homogeneous, very round, which has multiple small follicles, but there is one dominant follicle which is very smooth, less than 3 centimeters, not showing any vascularity. After ovulation, this entire dominant follicle shows crenated margin, crippled margins, and because it has undergone ovulation and the surrounding structure starts showing intense vascularity, which is called as ring of fire appearance, and this is a corpus luteal cyst. So whenever we see a dominant follicle, it is okay because it is round, oval, anechoic, and that is how it looks. Ovaries look smooth, the outline is smooth, the markings are smooth, there is no vascularity. In corpus luteal cyst, there is ring of fire, characteristic appearance, internal contents can be anechoic or hemorrhagic, but nothing to be done. So that is how they look on ultrasound. Postmenopausal females, since they do not have follicles, the ovaries tend to be very small and homogeneous, and they are rarely seen on ultrasound. So whenever we are doing an ultrasound for postmenopausal female, what we write as whether there is a adnexal mass or not. So just to brief up, that this is how a normal ovary looks on ultrasound. This is a transvaginal ultrasound, which shows hypoechoic cortex, echogenic medulla, very well-defined outlines, multiple small follicles as like string of pearl appearance, because it is in the early phase of the cycle, there is no dominant follicle. Then we go to the dominant follicle on TBS, that this is very smooth outline, no crenated margins, it is not a corpus luteal cyst, it is a dominant follicle less than 3 centimeters in size. Now, when it does not undergo ovulation, it forms a simple cyst which reaches up to 5 centimeters in size at times, but it has to be followed up if the patient is still in menstrual age or reproductive age group. Nothing to worry, it has to be followed up because it can undergo torsion. So this is how it looks. This is transabdominal. So transabdominal gives us an idea that there is a simple cyst which is quite large. We may or may not be able to characterize much on TVS, but still we would go ahead with TVS if there are any small papillary excretion we want to do. Now coming to cross-sectional imaging, because on ultrasound, it has become clear that we are able to identify structures. We are able to at times identify vessels also, especially whenever we are seeing the corpus luteal cyst, we are able to see the vascular supply, and we have a rough idea because the vessels are draining and coming from this aspect that this is the area of suspensory ligament. This is the area of connection of the uterus, utero-ovarian ligament. But we are not able to pinpoint that this is what is ligament, and that is where cross-sectional imaging overtakes the ultrasound. So we have to understand now on CT and MR, we are able to appreciate ligaments to some extent because it becomes important for us to characterize and to differentiate whether it is a adnexal mass or it is an extraperitoneal mass. So what are the landmarks which we have to always take into account is that these are the soft tissue structures, well defined. These are the ovarian tissues, and there is tongue-like projection going towards the uterus on the right side in subsequent section, which is utero-ovarian ligament, and these are the tongue-like projection which are carrying the ovarian vessels. That's a suspensory ligament. The ureters on the delayed phase are seen to lie posterior to the ovaries, and the external iliac vessels are quite far away and quite lateral to these vessels. On coronal reformated, we are able to appreciate in a female who has a left multilocular cystic lesion in the adnexa, uterus is kind of displaced. On the right side, we are able to see that this is the draining ovarian vein. Why draining ovarian vein? All these pempeniform plexus of the mesoovarium going and draining into the main channel, and this is the right ovary, which is in close proximity to the uterus. So these are the landmark structures which we have to identify, and they are easier demonstrable only in if there is a situs. This is uterus, this is broad ligament, this mesovarium, which is suspending the ovaries, broad ligament, ovarian, mesovarium. And on the left side, we are able to appreciate that the ovary is replaced by a mass. This is the area of suspensory ligament. We are saying that the ovaries are draining into the suspensory ligament. So definitely it is an adnexal mass. The ovaries can also be identified on CT because it has a poor soft tissue resolution at times. It is difficult by the presence of tubal clips or the ligation clips, that this is the area of the fallopian tube, because these are fallope rings, and this soft tissue is not a deposit along the bowel loops, or it is not a node, it is basically the ovary, and this is on the right side. Similarly, like the fallope rings, the landmark can be the suspensory ligament or the ovarian vessels, or the presence of some follicles which are showing peripheral enhancement in early age group females, which is basically just about to ovulate. In a patient, in the same patient, left ovarian or adnexal complex solid cystic mass, all these are the draining veins going into the suspensory ligament. All these are draining veins going into the suspensory ligament, and the ureter is posteriorly displaced. On the right side, this is the ovary, which is showing follicles. Presence of follicles makes it easier for us to differentiate or identify ovaries on CT. This is the right ovary, this is the left ovary. Presence of ascites makes us easily demonstrate that this is a broad ligament. This is the ovary, this is mesoovarium, this is the uterovarian ligament. Again, this is the broad ligament going that side. This is the ovary, this is the suspensory ligament carrying ovarian veins, and these are the ureters, which are lying posterior to it. At times it becomes difficult in certain settings to identify ovary. For example, if the ovaries are surgically transpositioned for fertility sparing in females with pelvic malignancies who are receiving RT, if the ovary shows presence of follicles, it is very easy for us to know that yes, these are the just transpositioned ovaries. And if the presence of surgical clip is there, it becomes very easy. But at times, if they are not showing any follicles, it becomes difficult and at times misinterpreted for deposit. So at that time, we have to look specifically whether there is any other deposit. If there is no deposit, try to identify if we are able to see ovaries in normal location. If not, try tracing the ligaments and try tracing the vessels. So this is a suspensory ligament reaching quite far into the lateral pelvis, surgical clip here, which is suspending, and the ovaries are transpositioned quite laterally here. This is a surgical clip for the other side, the ovaries quite higher up. These landmarks often help us to differentiate if the pelvic mass along the lateral pelvic wall is ovary or the lymph node. Lymph nodes usually lie in close relationship to the ovarian veins, unlike what we see in the other cases that they are quite far away from the ovarian veins. Whenever we are seeing ovarian veins, they are usually not effaced by the ovarian masses. So lymph nodes are usually here with no suspensory ligament or the gonadal veins reaching up to them, no follicles. In contrast, ovaries are usually ovoid with multiple follicles lying interior to it, and they are usually mobile, often changing position. In presence of large masses also, these landmarks often are helpful. This is uterus, this is a broad ligament, right ovary going to the lateral pelvic wall, but this is a large solid mass with very irregular margins merging into the pelvis for imperceptible margins along the cranial aspect, ascites. But what we see is that it is being supplied and drained by the ovarian veins, and the suspensory ligament is quite thickened up, and these are quite prominent ovarian veins. So we know that this is an adnexal and likely ovarian division of mass. Similar dilemma arises when we have solid masses. We do not know whether they are bilateral ovarian masses or whether they are conglomerate single, they have become contiguous masses. So whether it is a peritoneal deposits or they are ovarian or adnexal masses. So similar, we have to look for the landmarks. These are the ovarian veins draining into the right side of the solid mass, and these are the ovarian veins. The suspensory ligament, similarly on the left side, this is a suspensory ligament quite prominent. On the coronal reformation, we are able to appreciate that the ovarian or gonadal veins are quite prominent, even the arteries. So that means these are supplying these. And on cross-sectional, as we trace them cranially towards the drainage, these are quite prominent anterior to the psoas muscle and in the para-aortic locations. We are sure that these are ovarian innervation. So at times, these things becomes very difficult, especially if the patient has some tubo-ovarian masses which have become clumped. And at that time, we have certain difficult situation. For example, in this, there is a large mass which is kind of infiltrating the sigmoid colon. So we don't know whether it is a primary sigmoid colon malignancy or an adnexal mass. So again, we see the relationship. This is a broad ligament coursing anteriorly. The uterus is also quite anteriorly placed. And there are, when we trace this lesion cranially, we are able to appreciate that it is draining into the suspensory ligament, into the ovarian veins, which is going quite cranially. Ureter is quite far away from this. And this is basically an ovarian or adnexal mass which is infiltrating sigmoid colon rather than vice versa. So just to re-emphasize or revise the cross-sectional imaging on CT, CT is not the imaging modality for characterization, but it is very good for understanding the ligaments or the anatomy. So this is uterus, right side ovary shows an irregular cystic lesion with irregular margins, peripheral enhancement, craniated borders, minimal free fluid. So it is a corpus luteal cyst most likely, and it shows shows presence of suspensory ligament having the ovarian veins draining, supplying the right ovary. Similarly, we are able to see the suspensory ligament containing the ovarian vessels on the right side here, on the left side here. These are the reflections of the broad ligament going and anchoring the uterus to the lateral pelvic walls. The same thing is better appreciated in the subsequent section for the same patient. Broad ligament going towards the peritoneal reflections towards the lateral pelvic wall. These are the ovarian tissues with mesoovarium containing the pampiniform plexus. On the coronal reformation, we are able to appreciate that these ovarian veins are going and merging and to the pampiniform plexus of the mesoovarium. So now the same anatomy which we saw on CT is better appreciated in MR because it has a very good soft tissue resolution. We are able to appreciate ovaries, and we are primarily we are supposed to see T2 weighted image for anatomical delineation of the ovaries because the follicles contain clear fluid, and they bright up, they just light up on the T2 weighted images. All these are ovarian vessels which are very good and very nicely seen even without giving contrast. So that is the beauty of MR. So this is uterus, these are this is right ovary, this is left ovary containing multiple small follicles, and all these are the ovarian vessels in the going to merge into the suspensory ligament. In the presence of pathology at times, because it is difficult indeterminate masses, we do MR and we try to delineate and characterize what are these lesions. So these are multilocular cystic lesion, but we need to characterize whether it is tubo-ovarian masses or it is just adnexal ovarian cysts. So we see that these suspensory ligament vessels, ovarian gonadal veins are draining into it, and they are separate, multiple cysts which are separate, and we are seeing that the ureter is displaced to the other side. On the coronal also, we are able to appreciate that this is the residual kind of ovarian crescent sign. This is the residual ovarian tissue on both the sides, residual ovarian tissue on the right side, residual ovarian tissue on the left side. So we know that these are all ovarian cysts, and these are showing multiple fluid levels. So these are endometriotic cysts. So that is how we approach whenever we see a cystic lesion or multilocular, unilocular. We have to first thing is to characterize whether it is ovarian and non-ovarian, and that is where we approach the lesion. So that is where anatomy and all these landmarks come in handy. So the first and foremost step is always to localize whether it is intraperitoneal mass or extraperitoneal mass. So always see the displacement of the surrounding structures like the bladder, the iliac vessels of the ureter, and then see whether the vascular supply and the pelvic structures, how they're displacing the other structures. So if the ureter is displaced anteriorly, it is mostly extrapelvic masses. But if the ureter is displaced posteriorly and laterally, that means that is the anatomical location of the adnexal mass, because ureters are always posterior and lateral to it. If we are able to see any residual ovarian tissue, that is ovarian crescent sign. If we are able to trace the gonadal vein or the suspensory ligament, we are sure that these are adnexal masses. We at times it becomes difficult for the adnexal masses to differentiate from the uterine masses. So we are supposed to trace the uterine vessels. So these uterine vessels are going into this mass. So we know that it is a uterine origin mass or a subserosal fibroadenoma, in contrast to this extraperitoneal mass, a mesenchymal tumor, which is displacing the uterus anteriorly, the urinary bladder anteriorly, and we are able to appreciate that the left ovary lies separate to the mass, and these gonadal vessels are going towards the ovary rather than going towards the mass. So all in all, the basic anatomy and physiology is important because ovary is a structure which changes its shape, its size and appearance based on the menstrual cycles. The relationship with surrounding structures and correlation with the clinical presentation is very important, with specific attention to the vessels and ligaments, especially in the presence of ascites. We can beautifully trace all these structures. Ultrasound stays as the prime technique, and MR is problem solving, is what I would want to state, and the next speakers will continue with the same thing. Thank you.
It was a nice and elaborate presentation on radiological anatomy of ovaries and role of different modalities of imaging. As there is no questions on chat box, should I proceed to next presentation, madam?
Sure.
Yes, Dr. Rupa, I can see her. She's connected online.
Yeah, I'm there. I'm
Our
there,
next,
Palak. Yeah.
Our next presenter is Dr. Rupa Ranganathan, Division of Breast and Women's Imaging and Intervention, Department of Diagnostic and Interventional Radiology, Director, Breast Center, KMCH. Our area of interest are breast and gyne imaging. She will be talking on Introduction to Lexon and Recommendation for Ovarian Mass ORADs. I'm requesting Dr. Rupa Ranganathan to start her presentation. Madam, please.
Thank you so much, Palak and the Bangladesh team for giving me this opportunity. I hope I'm audible.
Sure.
Yes, madam.
So the topic for me is on ORADs, which is the standardized lexicon currently to describe ovarian lesions. First of all, let us see, why do we need a standardized reporting at all? It is to have a consistent interpretation, to decrease the ambiguity, to have increasingly correct diagnosis on imaging, not only diagnosing, but also to stratify the risk for that particular ovarian lesion, which finally results in optimal patient management. So ultimately, remember the ABC, whenever we see an ovarian lesion, it is accurate lesion characterization and for better interdisciplinary communication, which finally leads to correct patient management. That means a benign ovarian lesion, we can avoid an unnecessary surgery. And whenever we find a frankly malignant lesion, we can optimize the surgical outcome by referring the patient to the gynec oncologist. First of all, let us see these few 6 cases. So whenever we see these different type of ovarian masses, we tend to get away by using a simple term called a complex lesion. So the aim of this talk is to introduce you to certain terminologies in describing an ovarian lesion so that we no more use a term called complex lesion when we see an ovarian lesion. So there are different reporting systems that are available across the globe, and which includes ORADs, GYRADs, SRU guidelines, IOTA, and also University of Kentucky. But the commonly used reporting standards includes ORADs and the IOTA. Let us concentrate today on ORADs. The first standardized reporting system came from the International Ovarian Tumor Analysis, which is called IOTA, which basically describes the lesion as simple rules. By using easy descriptors, we directly assign that particular lesion as typically benign or malignant, and we also stratify the risk by using ADNEX model. ACR ORAD simply has incorporated many of the IOTA and the ADNEX model and have come out with ultrasound ORADs and MRI ORADs, which basically have 2 major components, which includes a reporting lexicon and risk stratification. And the broad guidelines when we use ultrasound or MR ORADs is it is used for an average risk patients and not for a high risk patients who already carry a genetic mutation. And when we evaluate an ovarian lesion, they do not present with acute symptoms. For example, we are not characterizing them when the patient is presenting with symptoms of torsion, and it is strictly not for non-ovarian, non-tubal origin, except for parovarian and peritoneal inclusion cysts, which is included in the ORADs classification. And whenever we sign multiple ovarian lesions, we have to give an individual assessment, and management is to be driven by the highest ORAD score. Like any other standardized reporting system, which includes BIRADS or TIRADS or PIRADS, the management is always driven by the highest ORAD score. And we classify women as premenopausal and postmenopausal. The definition for postmenopausal women is to when she has an amenorrhea for more than 1 year duration. And whenever we characterize a lesion with ultrasound, as Ekta said, it is always with transabdominal and transvaginal whenever possible. If transvaginal is not possible, we can even perform a trus ultrasound. And with MRI, it is always with contrast. That is how we characterize the MRI ORADs. We use a dynamic contrast where the temporal resolution is within 15 seconds. So as I said already, ultrasound ORADs, it has largely incorporated the IOTA lexicons and the ADNEX risk score from the data sets of IOTA 1 to 3. And it also has incorporated both European and North American approaches. By and large, compared to the ADNEX scoring, if you have the if you have already practiced ADNEX scoring, ORADs may appear to have a lower specificity. It is kept with the mind that we are evaluating an average risk patients, and hence ORAD tends to be more sensitive than specific. And like any other standardized reporting system which evolves continuously, this also will become better in future. In MRI ORADs, why MRI is used in ovarian lesions? Because when we have an indeterminate lesion after an ultrasound for quite a significant number of patients, which is around 20 to 25%, when we use the MRI in a standardized reporting terminologies and the risk stratification, the indeterminate lesion after MRI drops down to 5 to 7%. And this has incorporated largely the ADNEX MR scoring system, which came up in 2013. And when we apply ACR MR ORADs, it has got very high sensitivity and specificity. The sensitivity is close to 93% and specificity is close to 91%. And when there is no enhancement of the solid component within the ovarian lesion, the likelihood of malignancy following a contrast enhanced MRI is less than 0.01%. So it is highly specific to rule out a malignancy when we use MRI. Let us see both simultaneously. When we use the ultrasound ORAD lexicon, we have certain broad categories that is used to describe an ovarian lesion. First is called the major category, the size of the lesion, solid or solid appearing lesion, cystic lesions, vascularity, and general or an extra ovarian finding, which is very similar in MR. If you see, it also has a major category, size, shape, and contour of the solid lesion, signal intensity, the lesion components, enhancement, which is very similar to that of a vascularity and ultrasound, and an extra ovarian finding. So if you compare, most of the major, the lexicons are similar. The only addition we have in MR is the signal intensity, because we use different if it's physiological, we divide, somebody is trying to mute me. If it's physiological, it is divided as follicle or corpus luteum. And if it's an abnormal, which is pathological, which is lesion, it is divided as unilocular with solid components, multilocular with solid components, or solid components. Which is, let us see the example of each one of them. So this is a follicle and this is a corpus luteal cyst, which is basically a cyst with a hemorrhage, which has a rim of vascularity, as Dr. Ekta showed. So the pathological lesions are classified as unilocular lesion, multilocular, unilocular solid. When a unilocular solid lesion has got unilocular cyst has got a solid component, we call it as unilocular solid. When it is multilocular, when you see septations, complete septations traversing through the cyst, it is called multilocular. When you have a solid component within such multilocular cyst, it's called multilocular solid, and it is solid, entirely solid, or at least 80% of the ovarian lesion is comprised of a solid component. You call them as solid lesions. Major category in MR also is very similar to it as physiological and pathological. In divide them as cystic, lesion with solid component, or entirely solid. Let me show the example. So this is unilocular cystic, multilocular cystic, lesion with solid tissue. So whenever you see an enhancing solid component within a cyst, we call it as lesion with solid tissue, and a cystic lesion with other solid components. Those solid looking area which is not showing any enhancement is called other solid component, and frankly a solid lesion. The second component that we look is the size. So we measure the entire dimension of the ovarian lesion and also the maximum dimension of the solid component to categorize them on ultrasound. So the solid in ultrasound, we look not only this measurement, then we see the external contour and the internal contents. So whenever we see a cyst, we look the internal surface of the cyst. Whenever we see a solid area, we look at the external contour of the solid area. If the external contour is smooth or irregular, and what is the echogenicity? Is there any calcifications? Is there any acoustic shadowing, which is very similar to evaluation in MR as well. So this is an example of a regular solid lesion, where you can see the outer surface of the solid is regular, and you can see an irregular outer surface on ultrasound and irregular outer surface on MRI. So this is regular, this is a smooth, this is irregular outer surface. As I said, MR has got an additional component, which is a signal intensity. So we see whether the signal intensity is homogeneous or heterogeneous. Then how is the signal on T1, T2, and diffusion? So we evaluate with respect to iliopsoas muscle as hypointensity, with CSF as hyperintensity. So in various T1, T2, and diffusion, we compare it with a standardized normal structure to define whether it is hypointense or hyperintense. So these are some of the examples of homogeneous lesion, hypointense, hyperintense, heterogeneous, which has got a layering here. So these are different signal intensities that we see on T2. On diffusion, this is a typical example of B0, B800 in ABC, where there is no diffusion restriction. And this is an example, you can see there is increasing hyperintensity as you increase the diffusion, so which is a diffusion restriction. So the fourth component of the lexicon is the cystic lesion on ultrasound. As I said before, whenever we see a solid, we see the external surface of the solid component. Whenever we see a cystic component, we see the inner margin, whether it is smooth or regular, if it has a calcification, what is the content? Do we have a septation? Do we have a solid component on ultrasound? So this is an example of a smooth inner margin. It is an example of an irregular inner margin. You can see a small papillary projections. And it is very, very important to look for the acoustic shadowing because it predicts the benign nature of this lesion. So acoustic shadowing is one which you have to look for whenever we see a solid lesion. And whenever you see a septation, we have to see whether it is complete or incomplete. So incomplete septation comes under a unilocular lesion, and complete septation classifies the lesion as a multilocular lesion, and whether the contents are clear or whether it has a low level internal echoes. So hemorrhagic cyst, dermoid cyst, and endometriotic cyst, as we use in IOTA, are direct benign descriptors where you need not describe the lesion, you can directly categorize them as hemorrhagic cyst, dermoid cyst, and endometriotic cyst. Moving on to the MRI, where we see the lesion component, whether it is a simple or non-simple fluid. If you have a solid area, whether there is a papillary projections, whether it has a large solid component and it has a mural nodule, or whether the wall is irregular or a septation is irregular. So this is an example again for a simple and a non-simple fluid, and we can use all these additional descriptors on MRI. Again on MR, and we can classify directly as endometriotic cyst and dermoid cyst. As you can see, both looks has a varying signal on T2, but if you see a fat sat T1, you can see the dermoid shows the fat suppression because endometriosis has different shades of hemorrhage. It doesn't get suppressed on a fat sat T1, and enhancement again will be absent on an endometriotic cyst, and the solid component within the dermoid cyst may or may not enhance, and that is how we classify them based on the enhancement of the solid component. So these are another forms of different enhancements where you can see enhancing papillary projections, smooth enhancing walls, enhancing septations, enhancing solid components, which we call it a solid tissue, and these is an example of a non-enhanced solid component. So the vascularity and enhancement goes parallel. And the most important thing in vascularity in ultrasound is the technical factor. Look at this case where you can give a color score of maybe 2 here, but look at the PRF here. So whenever you evaluate a solid component on ultrasound in an ovarian lesion, we should make sure that the PRF is set low. It is recommended to have at 0.3 to 0.5. So 0.3, what is the vascularity score actually determined? So you may conclude by having a very high PRF in the machine setting as an avascular tissue. But if you look at the vascularity as a point, if you set the correct setting of PRF, you accurately can determine the vascularity of the lesion. Similar to that is the dynamic contrast enhancement, where you see the enhancement of the solid tissue. So how do you correctly evaluate? Again, the temporal resolution should be 15 seconds, which means the entire sequence of the ovarian lesion has to be acquired in 15 seconds for us to compare the enhancement of the myometrium and the enhancement of the ovarian tissue. So the temporal resolution is very crucial in MRI. The PRF setting is very crucial to characterize the solid component on ultrasound. So we have three different curves. The type 1 curve is low risk and the type 3 curve is a high risk for malignancy. And we categorize the MRI ORATs based on the kinetic curve that we obtain on MRI. So we also have an extra ovarian finding, which includes the peritoneal inclusion cyst, the parovarian cyst, the fallopian tube, and we can have fluid, whether it is seen only in the cul-de-sac, ascites, or the peritoneal thickening or the nodule and adenopathy. So this is an example of a hydrosalpinx. You know that the structure is a very tubular structure. It has got an incomplete septation. This is an example of peritoneal cyst where it takes the shape of the space that it is there. So it really does not have a very smooth cyst-like appearance because it can take any shape where it is located. And this is a parovarian cyst, wherein you can see the ovary separately from this cyst, and this is seen adjacent to the ovary, well separate from the ovary. So this is a parovarian cyst. Similarly, an example on MRI for a hydrosalpinx, peritoneal inclusion cyst, and a parovarian cyst. Again, you can see the ovary well. It is you don't see a rim of ovarian tissue covering the cyst, so you know that it is definitely not arising from the ovary, rather it is a parovarian cyst. So this is an example to show that there is an omental nodule, there is an adenopathy, there is a free fluid well away in the pelvis, and also the peritoneal nodules. So this is how we classify and the major descriptor. The second step after describing the lexicon is the risk stratification. So this is very freely available at the net. We can easily have access to how to classify. So the basic problem is to describe the lesion correctly. Interpretation and risk stratification is freely available, wherein we can interpret using these charts. So this is the MRI. So what is the summary of the risk stratification? So you will have it interpret as an ORATs too. Whenever you see a unilocular lesion, we do not mind the content of the cyst. It can be a simple cyst, it can be a hemorrhagic cyst, it can be an endometriotic cyst, it can be a dermoid cyst. As long as it is unilocular, which is less than 10 centimeter, or as I said, a classical benign descriptor, which is less than 10 centimeter, we can directly tell them that this is a benign finding and no further unnecessary investigation or surgery is required for these patients. And whenever you see a straight unilocular solid or a multilocular solid or an irregular solid, remember, whenever you see a solid tissue, interpret the color score of the solid tissue by using the optimal machine settings with a low PRF. And whenever you see an irregular solid lesion, when you directly see an ovarian lesion associated with ascites and peritoneal nodules, we know that there is a high chance for this lesion to be malignant on ultrasound. So the next investigation or imaging would be a direct CT, so that we know that this patient has a very high suspicious lesion. The gynae oncologist will ask the relevant blood investigations for that. The next step would be a staging CT for her. So we would not ask for an MRI when you directly see a frankly malignant lesion, because MR is used only for an indeterminate lesion and not for a typically benign lesion and a typically malignant ovarian lesion. So in an ORATs MRI, so we have quite a bit of ovarian lesions interpreted on ultrasound as indeterminate, and hence those group of patients are referred for ORATs MRI. So when will you interpret as definitely benign? When you see a unilocular cyst with no enhancing wall or solid tissue, and again a typical benign descriptor lesions, if they fall into a typical endometriotic cyst or a typical dermoid cyst with no enhancing solid component within, we interpret them as definitely benign. And when you have a solid tissue which has got a low on T2 and low on diffusion, so they are very hypointense, you can again describe them confidently as benign lesion, and an unnecessary surgery can be avoided. When you see an adnexal lesion with solid tissue with a kinetics of high risk, so it has got a high risk kinetics on dynamic contrast enhanced MRI, you also have a peritoneal nodules and omental thickening and nodules, the next imaging she requires is actually a staging CT, though people do MR for staging as well, but still CT is definitely much better than MR for a staging, which we will see later. Now let us look these 6 lesions again, and let us try to interpret them by using the ultrasound and the MRI lexicons and try to risk stratify them. Let's see one after the other. And I'm sure we will not interpret after seeing these lexical descriptors as a complex lesion. So the first case is actually a unilocular cyst. There is no vascularity. It is actually a retracting clot. So this is and you can see the ovarian tissue with the follicle here. So this is a hemorrhagic cyst. It is a straight ultrasound ORAD2. No further investigation is required. So we will not describe it as a complex cyst. We will describe this as a hemorrhagic cyst. We will use the benign descriptor as a hemorrhagic cyst. Again, the second case is again a unilocular cyst, hyperechoic content. There is lot of acoustic shadowing, no vascularity. Apply your benign descriptor. It is a dermoid cyst. Again, it is an ultrasound ORADS2. We don't need further imaging to confirm our diagnosis. The third case, this is again a solid appearing lesion. However, there is no vascularity. We use the right PRF of 0.3. Still, we did not have any vascularity within the lesion. So this is a solid appearing lesion with no vascularity. So this comes under ultrasound ORADS3. The next investigation of choice for her is to MRI to characterize this lesion. And again on MRI, we did not see any enhancement. So it is a unilocular cystic lesion. There is no enhancement. Now the indeterminate lesion on MR becomes a typically benign finding and no further surgery is required for her again. The fourth case we see is, that this is a typical solid irregular outer surface. She has got ascites, omental mass, MR, ORADS5 straight. There is a very different reason for which we have done an MR for her. So next step is to need a staging CT for her. So we have found ascites all the way up to the subdiaphragmatic regions. The next step, she has got omental masses. She has got irregular solid appearing, solid enhancing lesions in the bilateral adnexa. This patient underwent a neoadjuvant chemo and then a surgery. She's actually a case of high-grade serous carcinoma. The second last case, as I said, this was the case referred to us with the interpretation as an ultrasound ORAD3 because they did not use the correct PRF setting for her. So this was referred to us for MRI. This was a hemorrhagic content. The cystic component is hemorrhage. The solid area is showing enhancement. It is showing a diffusion restriction. We went back and did an ultrasound for her. We realized that she actually has got a color score of 4. We would not have actually asked for an MR for her. Rather, she would need a staging CT. So this was a multilocular hemorrhagic content, irregular inner wall of the cyst. Solid component has a color score of 4. So if you use the right setting, this should have been interpreted as ultrasound ORADS5. It is a high probability of malignancy. We don't need an MR for her because this was referred to us for MR. This has got a lesion with solid tissue, kinetics of high risk. Again, it was very high risk for an MR. The next step she would require is a staging CT and surgery. And this was a case of serous cystadenocarcinoma. The last case, this was a case of multilocular cyst, papillary projection, color score of very hypointense on T2. And this is not showing any diffusion restriction. So we know that this solid tissue is very dark on T2. You can see that it is very hypointense, no diffusion restriction. So a suspicious lesion on ultrasound was actually a typically benign lesion because she has got a lesion with solid tissue, which is dark on T2, dark on diffusion. And this is the case of typical benign serous cystadenofibroma. Cystadenofibromas are known to have acoustic shadowing of the papillary projections on ultrasound, and they are known to have a solid tissue which is very dark on T2, dark on diffusion. Again, an unnecessary surgery can be avoided for her. So how do we implement ORADs in our clinical practice? We will check with the patient that she belongs to an average category, average risk category with no acute symptoms. And first step is to ascertain whether the lesion of interest is from the ovary or not from the ovary, or it is indeterminate. And we describe them with using the major category, the type of the lesions, typical descriptors, and then we use the cyst, solid size, contents, inner wall, septation, solid component, and vascularity. Whenever we see a solid component, we will look at the size, outer wall, signal vascularity. We look for the associated finding, ascites, peritoneal nodules, lymph nodes, And with all these observations, we finally interpret using the ORADs. We describe the lexicons and we finally give them a risk stratification. So I have only one take-home message. Whenever you see an ovarian lesion, don't interpret them as complex lesion. Please try to interpret them by using standardized lexicons and use the risk stratification, which is freely available in the net, and categorize them using ORADs or IOTA and AdNextPro. Thank you.
Thank you, madam. It was really an excellent presentation on radiological ovarian morphology and adnexal reporting system. There are some questions on chat box. Should I read, madam?
I will see. Please explain acoustic shadow. So acoustic shadow is something that we see as an area of a dark line arising from the papillary projection. So we need to, a good transvaginal ultrasound with a very small FOV will help us to interpret the acoustic shadowing, which is even if you have a practice of placing the ADNIX model in your ultrasound system, when you share it, when you click that acoustic shadowing is present, the predictability of benign nature of such lesions are very high. Whether hemorrhagic cyst may have any low level internal echoes like endometriotic cyst. Hemorrhagic cyst can have a variable appearance on ultrasound. They can have a tightly packed low level of internal echoes, but it will not have something like a ground glass appearance that we typically see in an endometriotic cyst. Whenever you have a ground glass appearance within the cyst, in addition to that, if you have hyperechoic small nodules, avascular nodules adherent to the wall, the interpretation, it is very easier and it's very classical to call them as endometriotic cyst. Then sometimes when on MRI, if they don't have a T2 shading, it is very difficult to differentiate an endometriotic cyst and a hemorrhagic cyst. So sometimes it would be difficult if you don't have a classical endometriotic cyst. Doesn't matter, we can keep them on follow-up, because if you are not very sure, you can always call back the patient for ultrasound after 6 months. 6 weeks. If it is an hemorrhagic cyst, which is a functional cyst, it is expected to reduce in size or resolve. Does MRI done or needed for ultrasound indeterminate lesions? Yes, whenever you have an indeterminate lesion of ultrasound on ultrasound, be it you may not be sure about the organ of origin, or you may not be able to definitely classically categorizing them as benign or malignant, MRI is needed. I hope I answered all the questions in the chat box.
Thank you again, madam.
There is another question, Rumana, last.
Ask questions. Madam, will you read or should I read?
Is MRI done or needed for ultrasound indeterminate lesion?
I answered that question. Whenever you have an indeterminate lesion on ultrasound, the indeterminate component can be because of you're not sure about the organ of origin. So you can see a solid lesion, you may not be sure whether you're dealing with a fibroid or a solid ovarian lesion. We need MRI to categorize the organ of origin. And if you see an ovarian lesion in which you are not sure that they are typically benign or typically malignant, so we don't know what to recommend next. We cannot directly recommend a surgery because we may be recommending a surgery unnecessarily for a benign lesion. So categorize this lesion, MRI is again required.
Thank you, madam.
Thank you.
Now I want to invite our next presenter, Dr. Anuradha Chandramohan. She is professor and lead of Abdominal Imaging Services, Christian Medical College, Vellore. And her expertise is on onco imaging, abdomen and pelvis. Her research focus is on colorectal cancer, peritoneal malignancy, and gynecological oncology. Her topic today is pre-therapy assessment of disease burden and resectability criteria for planning cytoreductive surgery in peritoneal spread of ovarian disease. I'm requesting Dr. Anuradha Chandramohan, madam, to begin her presentation.
We have a question in the chat box. Does MRI is needed for indeterminate lesions, or would we stick with an ultrasound?
There is another question. If there are bilateral ovarian lesions, does it have any impact on ORAD score, or do you score individually or give a combined score? I think to Rupa Madam. This question is to Rupa Madam.
So till we have some time until Dr. Anuradha joins, may I like to know, since we have most gynecologists on board, how many of you all use reports with this ORAD scoring system?
Rupa, please.
Yeah, and Dr. Rupinder says in the chat that they get few reports with the ORAD score system.
Yeah.
So that is true, because not many clinicians report by the, not many radiologists also report by the ORADs. And I'm not sure whether the clinicians would want to know the ORAD scoring system. So that would be nice to know, because we work in a tertiary onco institute, and what we come across lesions which are more flagged as likely to be malignant. But so a gynae oncosurgeon gets a higher ORADs 4 or 5 category lesions to begin with. But when we look at the community in large with gynecologists, I want to know how your experience is with having something like an ORADs. And second question is whether anybody uses the RIMI index.
Yeah, but in our country, some of our radiologists, they reporting that they're ORADs. I think one of our radiologists, Dr. Rupa Sharmin Rupa, she has joined. Rupa.
Okay.
There's a question in chat box. If there are bilateral ovarian lesions, does it have any impact on ORAD score? Is it scored individually or give a combined score?
Yes, so it would be for the worst score. So if we have two different morphologies of ovarian masses, we would be giving the worst score, because the whole idea is for assessment of management. So it would be the worst score which will be given as a final score.
Thank you, madam.
Yeah. Okay, so I think Dr.
Now,
Anuradha has joined. We can continue with her.
Okay, madam.
Thank you so much.
In our country, some of the radiologists use ORADs, and it is very helpful. And another question was, if in case of two ovarian lesions, that is each side of ovarian lesion, the highest score is given, the highest ORADs are given.
I have seen Dr. Bonojaba and some of our radiologists, they reporting like the ORADs. Yeah.
And also Square Hospital, some of the radiologists in Square Hospital, they also use ORADs.
Topic given to me is the pre-treatment assessment of peritoneal burden, disease burden and ovarian cancer, and how this assessment helps in planning cytoreductive surgery. And thank you very much for allowing me to talk on this topic. Just before we start, I just take you through a few ovarian cancer facts. FIGO 2014 version has unified the ovarian, fallopian tube, and the primary peritoneal cancer, and the staging system is the same for all the three. And we all know that the epithelial ovarian cancer is the most common histological type of ovarian cancer. And within the epithelial ovarian cancer, since the majority of ovarian cancers are high-grade serous ovarian cancers, which occur in the postmenopausal women, and they present in a late stage, that is the reason why majority of the ovarian cancers that we see in our clinical practice present at a late stage. And the rest of it, the low-grade serous, mucinous, endometrioid, and the clear cell constitute the smaller percentage of the rest of the ovarian cancers. The other histological types like the sex cord, germ cell granulosa are even more rarer. This is important for radiologists because this helps in providing the information that is relevant for clinical decision making, and I'll show you examples of that. This is an example of a high-grade serous ovarian carcinoma in a 65-year-old patient, and this type of cancer is extensive. The masses are solid, soft tissue density, irregular masses, and the peritoneal disease is extensive throughout the peritoneal cavity. There is a lot of ascites in these patients, and this type of cancer is platinum sensitive but has poor prognosis. As compared to low-grade serous ovarian carcinomas, which occur in younger age group, It is uncommon type of ovarian cancer, constitutes only 5% of ovarian cancer. But among low-grade ovarian cancers, about 15% of them can show calcifications like we're seeing in this example. There's peritoneal calcifications, calcified masses in the pelvis. This type of cancer is important to recognize, and we need to tell our clinical colleagues in the oncology and the gynae surgeons. They have to know that we have identified calcified masses, because this will turn out to be a low-grade serous ovarian cancers which show poorer platinum sensitivity. So surgery would be a better option in these patients. And low-grade serous ovarian carcinomas, unlike the high-grade, which comes from the stick lesions, have a precursor lesion, and the precursor is a borderline serous ovarian carcinoma. In this example, is a multilocular cystic mass with irregular papillary solid component in a pregnant woman who was just 25-year-old. And this was a serous borderline ovarian tumor, a young patient. And notice that this papillary architecture that is present within this type of cancer is usually maintained even when they present later on as cancer. So when we look at ORATS 5 ovarian mass and endometrial thickening, is commonly an endometrioid type of carcinoma, which occurs in a setting of endometriosis. The other cancer that occurs in endometriosis is the clear cell carcinoma. And the type of ovarian cancers that we need to think of when there is associated endometrial thickening is also granulosa cell tumor, fibrothecoma, or a thecoma. So this was an endometrioid carcinoma, as I had mentioned, which is the most common cancer that is associated with endometriosis. And endometrial thickening in these patients is seen in 30%. It's a good prognosis cancer. And we already said clear cell is the other type of ovarian cancer that occurs in endometriosis. The rarer type of stromal cell tumors, the yolk sac tumors, and the dysgerminomas do not have any specific imaging characteristics, but the age of presentation and whether it's unilateral, bilateral, has a bearing in the type of histology we'll be thinking of in this group of patients. And knowing, being able to predict the type of cancer has a bearing on the type of cytoreductive surgery or the surgery that will be offered to the patient. So it is good for you to be aware of the clinical background, the tumor markers, and the kind of pathological spread of tumors in ovarian cancer when we're trying to have a discussion with a gynecologist. So how should we image ovarian cancer? CT is the main workhorse for imaging ovarian cancer. It's the first imaging modality on who present with abdominal distension and non-specific symptoms of cancer. So CCT is the modality of choice, and it has over 90% accuracy in staging ovarian cancer. So how will we achieve that kind of an accuracy? Only if we protocol our study properly. So what would a proper protocol be like? A proper protocol should include thorax, abdomen, pelvis, and venous space, so that there is adequate soft tissue resolution and difference between the different abdominal structures. We should use a positive oral contrast because it helps in identifying mesenteric and small bowel serosal disease, and I'll show you examples of that. Using a split bolus technique we have found is very useful because it helps delineate the relationship of the mass with the ureter. So we regularly use a split bolus technique in a patient with ovarian cancer or any suspected pelvic mass in our center. Also, reviewing images in thin sections, that is 2 millimeter sections, is very useful, and always review images in both axial and coronal. Contrast thin sections, images in axial and coronal. this is an example to show you value of positive oral contrast, and a very gross example with mesenteric tethers. Gross example, given positive oral contrast, there are certain, there is all the soft tissue densities that is indenting, distorting the loops. So this kind of soft tissue masses can look very similar to collapsed bowel loops, and in a patient with more subtle small bowel mesenteric involvement, administering positive oral contrast will help you differentiate small bowel serosal disease from collapsed bowel loops, and also it will help us appreciate subtle bowel findings like bowel luminal distortion and bowel kinking in a better fashion compared to using neutral contrast. One might argue, what about calcified peritoneal nodules? Won't it get obscured by giving positive oral contrast? But as I previously showed you, low-grade serous ovarian carcinomas, which has these somamatous bodies or the calcifications, are much less common. They constitute only 5% of all the ovarian cancers. So we better have a protocol that will deliver to majority of ovarian cancers. So I think it is very useful practice to give positive oral contrast rather than withholding positive oral contrast, thinking of those very small percentage of patients who might have calcified deposits in the peritoneal cavity. So what is the role of imaging in ovarian cancer? The role of imaging is threefold. Even while planning cytoreductive surgery, we always have to keep these three roles of imaging in mind. First of all, we need to always start reviewing the imaging, thinking of confirming whether it is an ovarian cancer or not. Secondly, we should be able to stage the ovarian cancer and then prepare for the decision, prepare to deliver, answer questions for the decision time. That is when we will help the gynae-oncologist decide on the line of management for the patient. So let's look at each of these roles one by one. So is it ovarian cancer? This is very important question for us in this part of the world, because abdominal tuberculosis, peritoneal hydatidosis, these are all very common infections in our practice. Time and again, we will see these kind of cases getting into the gynae-oncology MDT discussions. So we should be able to recognize the differences between benign and malignant peritoneal thickening. Benign peritoneal thickening, like in this example of tuberculosis, will be diffuse and it will be smooth, and there will be intense enhancement of the peritoneum. Both visceral and the parietal peritoneum will be uniformly involved in tuberculosis. And also ultrasound will typically show this multilocular ascites. So these findings should make us lean more towards an infective inflammatory pathology compared to a neoplastic pathology, which will have irregular nodular peritoneal thickening, and the degree of enhancement of the peritoneum will not be like as intense as an inflammatory pathology. There's an example of peritoneal hydatidosis, very extensive. Notice multiple cystic lesions in the peritoneal cavity, some with calcification, and it is extensive throughout the peritoneal cavity. We should not mistake this for a malignancy. Ultrasound will be very useful. Demonstration of trilaminar pattern of the wall using a high frequency ultrasound probe is a very useful add-on to a CT scan, which has this appearance. Thirdly, it's very important in every single patient who has ovarian cancer, the radiologist must review certain organs. Most commonly, the stomach and the colon must be reviewed in every single patient who presents with bilateral adnexal masses, because primaries, these primaries causing Krukenberg's tumor constitutes over 80 to 90% of all Krukenberg's tumors. So in every patient with ovarian masses, radiologists must review the stomach and the colon and the appendix to exclude primaries in these locations. I've shown you two examples of solid bilateral ovarian masses, one with a smooth surface, other one with a lobulated surface. So these examples are from stomach cancer. As I've shown you on the right side of the slide, 80% of Krukenberg's tumor will be bilateral, 80% will be solid. And when we have solid Krukenberg's tumor, always think of these primaries and review these areas to exclude primary in these locations: the breast, stomach, lymphoma, and the uterus. When you see cystic ovarian masses, think of colorectal primary, appendicular primary, or biliary primary, and cystic and unilateral Rickenbachs can be seen in up to 20% of patients. We often come across primary peritoneal carcinomatosis, though it's a rare diagnosis. Only 7% of all patients who go and undergo a cytoreductive surgery will come back with the final diagnosis of primary peritoneal carcinomatosis. It is a diagnosis of exclusion in histology. It is similarly a diagnosis of exclusion in imaging. We can suspect primary peritoneal carcinomatosis when there's disproportionate peritoneal disease, like in this example with extensive omental caking, mesenteric tethering, mesenteric fold thickening, massive amount of ascites, diffuse peritoneal thickening, but normal sized ovaries. In older women, almost a decade older than the usual high-grade serous ovarian carcinomas. The usual age group of presentation of primary peritoneal carcinomatosis is in the 7th decade. So when we have this constellation of finding with normal ovaries, extensive peritoneal disease, no other primaries found, you can give a differential diagnosis of primary peritoneal carcinomatosis. And we should not, in our practice, put our foot down and say this is primary peritoneal carcinomatosis, the sole diagnosis on based on radiology findings alone. And pseudomyxoma peritoneae, again, is something that we come across in our practice time and again. So when we have scalloping of liver surface in this fashion, omental caking of low density, suspect pseudomyxoma peritoneae. The primary organs to review when you see this kind of appearance is the colon, appendix, biliary tree, as I said, and the pelvis for ovarian primary. Only when one has excluded appendicular primary, colorectal primary, should you call it ovarian origin pseudomyxoma peritoneae, because appendicular origin pseudomyxoma peritoneae are way more common compared to ovarian origin pseudomyxoma peritoneae, and both can also occur concurrently. So always when we see this appearance, do not forget to review the appendix. This is a classic example of mucocele of the appendix with bracket calcification. First with an intact mucocele, second with a ruptured mucocele of the appendix with the calcified mass embedded within the ruptured mucocele of the appendix. Very rarely we can come across this kind of omental caking with cystic lesions within. So when we see this kind of cysts which are diffusely spread throughout the peritoneal cavity, also think of a rare diagnosis such as multicystic mesothelioma. This particular diagnosis, radiologists can be very helpful in guiding the oncology team towards this diagnosis, because this is an aunt mini. When we see this kind of appearance, one can be sure of the diagnosis and guide the pathologist to do the appropriate immunohistochemical markers. Just as another common mimic of ovarian cancer, so when we see abnormal vascularity, which is not the usual type of vascularity that we see in ovarian malignancy, do not forget to review whether or think of a bowel origin mass such as a GIST. Leiomyomatosis can rarely mimic a ovarian mass, and this is another diagnosis that can mimic the ovarian cancer. So after having looked at is it ovarian cancer, let's move on to the stage. Stage 1 ovarian cancers, the tumor is confined to the ovary. In 1C, there is little bit of peritoneal spill. It's very important not to biopsy or aspirate an adnexal mass without consultation or without the gynae oncologist referring the patient to the radiologist for aspiration or biopsy. That's very important, because if we inadvertently spill tumor cells from a 1A and make it a 1C, there will be a big difference in the disease-free survival of these patients. So we should not play a part in that. So always wait for these patients to be referred by a gynae oncologist before we attempt the aspiration of an adnexal cyst or a mass. Stage 2 ovarian cancers are tumor that is confined to the pelvis. So all the structures that are involved are below the pelvic brim. Rectum, sigmoid, ureters, when they are involved below the pelvic brim, it's a stage 2B ovarian cancer. Stage 3 ovarian cancer, the A component has lymph nodes, and A2 is microscopic peritoneal disease. A1 is when there is retroperitoneal nodes, but they are less than 10 millimeters in size. A12 is metastasis to larger nodes greater than 10 millimeters in size. Whereas 2B is peritoneal implants seen macroscopically, but they are less than 2 centimeters in size. And 3C is when the peritoneal deficits are greater than 2 centimeters in size, but they might be anywhere above the pelvic brim, including along the diaphragmatic surface and along the splenic and liver surface. Stage 4 disease is spread outside the peritoneal cavity or metastasis to solid organs such as liver, spleen. 4A is when there is pleural effusion, but we have to call it 4A only when we demonstrate positive cytology. 4B cancer is metastasis to extraperitoneal organs such as even inguinal lymph nodes, cardiophrenic lymph nodes, and lymph nodes above the celiac trunk also come under 4B stage. And similarly, a transmural small bowel infiltration is also a 4B disease. These are examples of umbilical nodule, which is again a 4B disease, inguinal lymph nodes, and axillary lymph nodes. So let's go on to the main topic for today, which is helping with the decision time for the patient. For that, we need to know what are the lines of management of ovarian cancer, which includes primary cytoreductive surgery. If the disease is too extensive, then the team will decide on neoadjuvant neoadjuvant chemotherapy to downsize the peritoneal disease burden, and then reassess for interval cytoreduction. Or in a small subgroup, the oncology team might decide on interval cytoreduction with or without HIPEC. When the disease is extensive, they may decide on palliative chemotherapy. Why is assessing peritoneal disease burden so important? It's because the most important factor that determines the length of survival of the patient is the completeness of cytoreduction. That is the one thing that has been consistently, it's been shown in multiple studies as the most important prognostic factor. So that is the reason, and achieving completeness of cytoreduction is very dependent on the likelihood of, on the operability, and which in turn is dependent on the disease burden in the peritoneal cavity. So accurate estimation of the disease burden is very important to be able to tell the surgeon whether complete site reduction is achievable or not. The purpose of site reduction is to achieve either complete site reduction, which is ideal, or at least optimal site reduction, which is where only less than 1 centimeter of disease is left behind within the peritoneal cavity. Only R0 and R1 resections will translate to survival benefit. If it's an R2 resection, there is no difference in the survival outcomes of a patient who undergoes an R2 resection or only chemotherapy. So in effect, if a patient undergoes interval cytoreduction with following chemotherapy and has an R2 resection, we have not given the patient any survival benefit. So it's important to, before putting in so much of resources, time and effort into treating a patient like that, we need to know whether complete cytoreduction is possible or not. So let's see how imaging can help in predicting completeness of cytoreduction. There are multiple models to predict prognosis, which have taken into account the tumor markers, imaging features, or a combination of tumor markers and imaging features. And there are also scoring systems based on staging, laparoscopy, and laparotomy. So out of all these systems, I'm going to take you through one system that we have found it very useful as a radiologist. Communication between the clinical team and radiologists can be very effective when we think of findings along these lines. So we devised this acronym called PAUSE, to be able to effectively communicate important findings that are seen in the peritoneal cavity. Where P stands for primary. In ovarian cancer, it can also include pelvic extent, and third is a PCI. A stands for ascites and abdominal wall disease, U for unfavorable sites, S for small bowel mesenteric disease, and E for extraperitoneal disease. So about the first component, our first task is for the radiologist to exclude other primaries, which we already saw, and be able to decide whether it's high or low grade serous malignancy, and to assess the local extent. By local extent, we mean the disease below the pelvic brim. The planes between the rectum, the sigmoid colon, and the ureter are very important because it helps the surgical team in deciding whether they need intraoperative help by colorectal surgeon or other team urology, urosurgeons to assist in the pelvic surgery. So it also, these decisions also depends on the expertise available in each center. So telling the surgeon the findings within the pelvic brim will help them assess the complexity of surgical procedure and also counsel the patient on the need for colostomy, for example. The other important feature is to tell them whether the pelvic side wall is infiltrated or not. The definition for pelvic side wall infiltration is a distance of less than 3 millimeters between the soft tissues, that is the muscles of the pelvic side wall and the tumor, or if there is greater than 180-degree encasement of the iliac vessels, or if there's complete occlusion of the iliac vessels or irregularity of vessel wall. These findings are very important to mention because that would prevent the surgeon from achieving complete cytoreduction. This is an example of complete sigmoid colon encasement and lost plane with the rectum, suggestive of rectosigmoid infiltration. In this example, I've shown you split bolus technique. Notice the positive oral contrast within the renal pelvis on both sides. Split bolus technique, as I said before, will help us know the plane between the ureters and the pelvic structures. What we do is give 40 ml of IV contrast when the patient is waiting outside 10 minutes prior to the CT scan. And then we take the patient onto the gantry and administer another 80 ml of IV contrast on the table at a rate of about 3 to 4 ml per second and perform a CT thorax, abdomen, pelvis. By doing that, we will be able to delineate the positive ureter with the positive contrast, and we'll be able to show the relationship of the ureter between the ureter and the soft tissue around the ureter. This is an example of the right ureter encased by the soft tissue mass in this patient. This is an example of right pelvic side wall infiltration, and even on the left side, there is almost 180-degree encasement of the iliac vein. Next, let's go on to PCI. So PCI is peritoneal cancer index, which is basically adapted from Sugar Baker's peritoneal cancer index, which is a surgical index. But all those areas can be very well seen on a CT scan. So the cutoff is very variable for ovarian cancer. Initially, they started off with 20 as a cutoff to select patients who are amenable for primary cytoreduction. And the newer literature says that a PCI of 13 or 16 might be a better cutoff to determine whether complete cytoreduction can be achieved or not. But there are mixed results as to how this peritoneal cancer index translates into survival outcome. Still, studies are evolving in this topic. But as of now, we need to know that CT scan underestimates peritoneal cancer index. So when a radiologist says that the peritoneal cancer index is very high, it is very highly likely that there will be extensive disease in the peritoneal cavity. What CT will miss is nodules that are smaller than 5 millimeters. This is instead of taking you through the entire peritoneal cancer index, I'll give you certain tips. These vertical lines are drawn along the mid-clavicular line, And the horizontal lines are along the lower costal margin and the ilia crest. And this divides the peritoneum into 9 quadrants. Then the small bowel loops are divided into 4 quadrants by drawing a line along the midline and one line along the horizontal, in the midline. A horizontal line is drawn to divide the peritoneal cavity into 4 quadrants, which divides the 4 small bowel parts. The sum of scores that are given to each of these quadrants based on the size of the largest peritoneal disease seen in that area gives us the PCI. Though it looks very cumbersome, we can actually finish assessing the peritoneal cancer index with practice within a few minutes. Maximum, it takes only 3 to 4 minutes with practice. And we don't need to use a caliper or a scale to accurately measure these masses in the different areas of the peritoneal cavity. Radiologists are very good at eyeballing whether a tumor seen in that area is greater than 5 centimeter, or is it less than 5 centimeter, or is it less than 0.5 centimeter. So we can quickly look at it visually and assess the peritoneal cancer index. The other tip about assessing peritoneal cancer index is the greater omentum, though it can span from region 3 to 7, it should only be counted as region 0. So omentum can extend from top to bottom, but it only belongs to region 0. And in ovarian cancer, there could be large masses in the pelvis, and these masses are not counted as a part of the peritoneal cancer index. So ovarian masses must be excluded in the assessment of peritoneal cancer index. So these are the things that we need to take care of while assessing PCI. Let's move on to ascites and abdominal wall disease. Large volume ascites is known to be a poor prognostic feature. And similarly, when there is abdominal wall disease, it's a stage 4B disease. But a midline umbilical nodule can be excised. But whereas lateral abdominal wall nodule within the rectus muscle or a more extensive lateral abdominal wall disease can literally contraindicate or a cytoreductive surgery, because it would be impossible to close the abdomen after excising such a large abdominal wall metastasis. So this could be a relative contraindication for an extensive cytoreductive surgery. More than PCI, recognizing unfavorable sites of disease involvement is important, because that's the feature that will affect removal of disease completely from the peritoneal cavity. So more than the PCI, unfavorable sites are important. We've divided the unfavorable sites into no unfavorable sites, those findings that would cause increased surgical complexity. So U1 findings which increases surgical complexity must be listed out by each individual surgical team based on the surgical expertise available within their team. And U2 are findings when present definitely will prevent complete site reduction to be achieved. So that is a very important list of findings that one must need to review and mention in our reports. So example of U1 sites in our center would be something like regions in the epigastric region, retroperitoneum, or the pelvis. Epigastric regions would include the lesser omentum, lesser sac, fissures of the liver, ligaments, and left gastric artery encasement, disease in the lesser sac. These things would fall under U1 findings. Similarly, the portocaval space, gallbladder fossa, presence of disease in the splenic hilum, and stomach encasement. So stomach encasement would mean need for gastrectomy, and so that would become a U1 site. Similarly, retroperitoneum, when there is extensive ureteric encasement or psoas muscle infiltration, complete site reduction would be very difficult to achieve, or there might be need for ureteric reimplantation and need for involving the urologists, and these things have to be looked for and mentioned in the report. Similarly, in the pelvis, when there's bladder involvement and vessel encasement, we need to look for it and mention our reports. When is R0, R1 unlikely? When there is a thick diaphragmatic disease greater than 2 centimeters in thickness in the diaphragm along the lesser omentum or the liver fissures, complete site reduction is not possible. This must be mentioned. Similarly, biliary obstruction, multifocal small bowel serosal disease, mesenteric disease, root of mesentery, especially if it's involved, complete site reduction is not possible. Pelvic side wall infiltration, nodes above the celiac trunk. These constitute very important list of features which we must definitely comment upon in our reports. This is an example of disease in the intersegmental fissure, very thick, greater than 2 centimeters in thickness. There's a nodule in the lesser sac. That's greater omental thickening. This is a disease along the lesser omentum showing and it is FPG avid. There's a large deficit in the gallbladder fossa. That's omental caking and some ascites in this patient. Disease in the gastrosplenic ligament, which is going into the gastrocolic ligament in this patient. Thick rind of plaque-like soft tissue along the diaphragm and measures greater than 2 centimeters. That's definitely a very significant finding. And disease in the mesentery, entire mesenteric fold is thickened and nodular. Another example of small bowel mesenteric disease completely encasing the small bowel. This is extensive mesenteric disease. There are mesenteric nodules as well. You only look at this area, there's mesenteric clouding and ill-defined nodular thickening of the mesentery. So those findings are also very suggestive of mesenteric disease. This is another example where the mesentery is just fanned out and it's kind of literally showing off its architecture. So when that kind of mesentery is seen, that is again a sign of mesenteric disease. Closer look at that mesentery shows you multiple nodules and a very misty mesentery in this area. This example, which we already saw, where I showed you the importance of positive oral contrast, bowel kinking and bowel distortion by soft tissue masses in the mesentery. The small bowel loops are not floating, it's actually tethered towards the posterior abdominal wall, and that's a definite a feature that definitely will not allow a complete cytoreduction to be achieved. This is an example of transmural infiltration of the small bowel by the adnexal mass, and this causing small bowel obstruction, a feature of a 4B ovarian cancer. And when it is unifocal, surgery is possible. When similar kind of disease involves multiple small bowel segments, then again, that's an important finding to mention. And also in these patients, it's important to note this because ileostomy, when it's done on these patients, would be very high and will not be useful. So even if these patients obstruct, ileostomy may not be possible when it's multifocal and proximal small bowel. When proximal small bowel is involved, it will not be useful. So we need to mention that in our reports. So what we see on images, the small bowel mesenteric involvement is usually very extensive like this. What we would miss on imaging is this miliary nodules and plaque-like disease in the mesentery. And so when we see mesenteric and small bowel disease on imaging, it's a very significant finding, and that must be highlighted in our reports. The E component is basically infiltrating liver serosal disease when metastases greater than 4 are present, inguinal cardiophrenic lymph nodes greater than 7, lung and pleural metastasis. This is an example of disease along the liver surface. We can see it indenting the liver, but we look at this serosal deficit, it is actually going quite into the parenchyma. So that would be an infiltrating serosal metastasis. If you notice all these 3 nodules, which is along the serosa, they make obtuse angle of contact with the liver parenchyma. So that tells us that it is extrinsic to the liver and indenting the liver from outside. Show another example differentiating liver metastasis from serosal deficits. These are liver metastasis where it makes acute angle of contact with the liver surface, whereas an extrinsic deficit, as in this example, makes an obtuse angle of contact with the liver. So these are that's how you differentiate between liver metastasis and serous cell deficit. Lastly, malignant pleural effusion must be mentioned in our report, and do not forget to look for cardiophrenic lymph nodes, whether they are enlarged or not. The size cutoff is 7 millimeters. This is our own study, which shows that even in the developing world, presence of cardiophrenic lymph nodes should not be assumed to be inflammatory. It still indicates stage 4B disease and a high volume peritoneal disease, and also was associated in our study with non-regional nodal disease and extraperitoneal disease, and was associated with lower recurrence-free survival. So these are other examples of extraperitoneal disease in the inguinal region and axillary region. So what is the usefulness of assessing POS in this fashion? Is it clinically useful is a very pertinent question. This is our own data, retrospective data on 63 patients with stage 3 and 4 epithelial ovarian cancer, where 49 had complete cytoreduction, the rest had incomplete. And this is how the ROC curve looks. So when a POS score is given, to each of these findings, we are able to positively differentiate these two groups, optimal and suboptimal cytoreduction, in this retrospective cohort. But the study has its own limitations because it's retrospective. Both those who received neoadjuvant and primary cytoreduction were clubbed into a same group. So it has pitfalls because of that. So there is certainly scope for prospective studies, recruiting patients separately for looking separately at primary and interval debulking groups to assess how it translates to predicting optimal and suboptimal cytoreduction. So we've seen the role of imaging in ovarian cancer. Is it useful? Is it ovarian cancer? What is the stage and how imaging can help with the decision time? So the take-home message from this is to just pause and look at all these components of POS and imaging. And this is very useful in communicating findings with the MDT team that looks after ovarian cancer patients, and helps with MDT decision making and has potential for predicting outcomes of cytoreductive surgery. Everything that I had mentioned today is in this article that we published, and we've also given you a comprehensive structured reporting format, which is based on the POS, which is published in JGAR, and you can take a look at that. And these are some of the further reading which might be useful for those who are interested. And I want to finish by showing you this picture of the Vellore Fort in our city, lit up for the 75th Independence Day. Thank you very much.
Thank you, madam. It was a really very much informative lecture about preoperative assessment and receptibility predicting through CT scan and imaging, and which will help in treatment planning in ovarian cancer patients. There are some questions, madam, in chat box.
Yes, please.
Madam.
Yeah.
One question is from Divya Sehra. She asked, how do you predict ureteric encasement?
So that we can see Anuradha.
Oh, okay.
Anuradha, please stop share your screen.
Okay, I'll stop share. Yes, please. Yeah.
Madam, should I read again?
Yeah, please go ahead. Yeah.
How do you predict ureteric encasement?
Ureteric encasement, yes. So ureteric encasement, basically, if it is greater than 180-degree encasement of the ureter, then we certainly highlight that in our report. And it may or may not be involved at surgery, but it's very useful to know that the mass might be involving the ureter, because they don't have to suddenly make quick decisions during the operation. They can inform the urology team ahead that about this particular finding, so that they can be kept informed of the need for ureteric reimplantation or other quick modifications of surgery. Yeah. So 180-degree encasement and also presence plus or minus hydronephrosis.
Okay.
Yeah.
Thank you, madam. There is another question. How do you identify fat plan between mass and gut wall or bladder?
Sorry, tell me again. How do
you identify fat plan between mass and gut wall or urinary bladder? What does it indicate?
Okay, mass and the lateral urinary bladder.
Gut wall and bladder, fat plan between.
Yeah. So yeah, basically CT is not fantastic with determining the plane between the mass and the pelvic structures, but we can attempt to say whether the plane is involved or not. So in our center, we insist that the patient voids about hour, 1 hour or half an hour before the CT scan. We would prefer the bladder to be empty when the patient is undergoing the scan, because we don't want planes to get more obliterated because of over distension of bladder. That is something that we take care of. So in a contracted bladder, it is little more easy in predicting the plane between the pelvic mass and the bladder. And bladder infiltration has to be a full thickness infiltration. That is what is infiltration. Just detrusor involvement is not bladder infiltration. It might be adherent and still might require a removal of part of the bladder. But it is difficult to make out on CT. So that is what we do. We look for loss of fat plane. And when it is indenting and distorting the bladder, we tell that to the surgeon, but with the caveat that we may not be very accurate on CT. Yeah.
Yes, madam. Is there any scoring system in preoperative CT scan finding to predict resectability? I think I've answered this.
Yeah.
Another question is, what is the radiological PCI score with huge ovarian mass, which looks like malignant, but with no disease elsewhere?
Yeah, so in that patient, the PCI score might even be 0, because there might not be omental caking, there might not be peritoneal thickening, there might not be disease anywhere else. So then the PCI is actually 0. Ascites is not a part of PCI, and ovarian masses in an ovarian cancer is not a part of PCI. So PCI would essentially be 0 in that patient.
Madam, next question is, often conglomerated retroperitoneal lymphadenopathy involving aorta and vena cava renal vein is a contraindication to primary surgery. How is radiological PCI predictive of it? Or do you need to separate subset?
Yeah. PCI only spells out the disease in the peritoneal cavity. It does not say anything about extraperitoneal disease. That is why POS is so important, because it has all the components that are important for the management. The U component and the E component of POS will address all those findings. But the PCI is not meant to do that.
Yes, madam. Another question, if a patient has only omental nodules or caking, no definite ovarian disease seen on imaging, other clinical findings favors for ovarian primary, what will be the next diagnostic tool?
Okay, only omental caking.
Omental nodule or caking, no ovarian disease seen on imaging.
You have only omental caking, but no other disease elsewhere. Is that what you're saying?
No ovarian disease seen on imaging.
Okay.
Next, what diagnostic tool should be done?
So if the radiologist is confident that they have reviewed the stomach, the colon, the appendix, and they've looked for other primaries and they're not able to find another primary, in our center, we would advise them still to undergo an upper GI and a lower GI scopy. And we would correlate with appropriate tumor markers, that is CEA, CA99, And sometimes we would also resort to a mental biopsy in these patients because we don't have a diagnosis. All peritoneal disease may not be ovarian. It might be a primary other peritoneal malignancy like peritoneal mesothelioma, for example. So it could be other peritoneal malignancies. So there is a role for ultrasound guided biopsy of the omental caking and to prove the diagnosis and then treat the patient in that case. Yeah.
A question from Bhagalakshmi Nayak, madam. What is the characteristic picture of borderline ovarian tumor? Does imaging tell us about histopathology of probable histopathology of tumor?
Yes, there have been very good imaging papers on borderline ovarian tumors, but there are very few of them which give us accuracy ranging between 60 to 80%. And the classic feature is that the outer margin of a borderline ovarian tumor, the surface of the mass is going to be smooth, and all the architectural abnormalities within the ovary and classic solid papillary excrescencies in a multilocular cystic lesion is very much suggestive of a serous borderline ovarian neoplasm. And a mucinous borderline ovarian neoplasm is multilocular, and each of those locules have different density, but there is no solid components usually. So those findings will help us in finding out whether these are borderline or not.
Thank you, madam. It was an excellent question answer session. With this, we are now ending our session 1, that is presentation session. And we will now move to our session 2, that is panel discussion session. Should we proceed to our panel discussion session, Shana madam?
Yeah, we can carry on, yeah.
Yeah, sure. But there are some questions she can answer.
I'm just wondering if you're
Madam, I have already asked all these questions. She has answered.
The mass better CT, MRI, does imaging tell us the histopathology of the tumor? There are some small
Madam, all questions has been asked, madam.
questions.
Okay.
You wanna proceed?
I'm requesting Dr. Anbu Subian, madam, to start the panel discussion session and moderate the session.
Have you introduced them? Is there a
Oh, I think I was muted. Okay, madam.
yeah, that is. You didn't introduce any of
Okay.
them.
Yes, madam.
Okay.
Yes. Today's moderator of panel discussion session is Dr. Anbu Subian, madam. She's consultant gynae oncologist, Kovai Medical Center and Hospital, Coimbatore, India. She's executive committee member, Tamil Nadu RCOG, and executive committee member, AGOI. As panelists, we have with us Professor Dr. Amita Maheshwari Madam. She is Professor and Head, Department of Gynae Oncology, Tata Memorial Hospital, Mumbai. Dr. Joya Ghosh, she is Professor, Department of Medical Oncology, Tata Memorial Center, Mumbai, India. We also have Dr. Supriya Chopra. She is Professor, Clinical Research Center, Advanced Center for Treatment, Research and Education in Cancer, Tata Memorial Center. And Dr. Anuradha Chandramohan. She is Professor and Lead of Abdominal Imaging Service, Christian Medical College, Vellore. Now I am requesting Dr. Anbu Subian Madam to start the panel discussion session and moderate this session.
Thank you so much for the invitation. May I please share my screen? Is my audio video okay?
Yes, madam.
So thank you for giving us this very crucial panel discussion where we focus on how does a radiology report answer key questions prior to embarking on therapy in ovarian malignancies as well as its surveillance. A warm welcome to my panelists, Dr. Anuradha, who's just now given an excellent talk. And I believe that it is going to be kind of like a wrap-up of things she said in a very short time. And I hope we get some key take-home messages from her. Dr. Amita, who's a professor of gynae oncology at Tata, Dr. Supriya Chopra, who's a radiation oncologist, and finally Dr. Jaya Ghosh, who's a medical oncologist. Before I start off, let me dive right in and present a common scenario that we see in a general gynecology practice. This is a 40-year-old Paris female who presented with complaints of heavy menses and postmenstrual spotting, severe dysmenorrhea, many years. And
Ambu, please be a little louder. Please. Ambu, please be a little louder.
Yes, ma'am. This is a 40-year-old Paris female who presented with complaints of heavy menses, postmenstrual spotting, severe dysmenorrhea for many years. She was clinically comfortable, stable, and her examination of the abdomen revealed a mildly tender suprapubic mass extending up to the umbilicus. There were no other relevant abdominal findings. On vaginal exam, it revealed a mass that was a cystic mass, predominantly that was felt high up with a very smooth POD, and the uterus in this patient was not clearly palpable. As we all have encountered in our practice, an ultrasound report was already available. And this is what it actually said. She had a bulky uterus with multiple intramural fibroids, which probably explained the many years of abnormal uterine bleeding. She had a right ovarian cyst, which was approximately about 15 centimeters with homogeneous internal echoes with solid area, one solid area measuring 0.4 centimeters. Left ovary had a small hemorrhagic cyst, which was approximately 3 centimeters. The ultrasound did not report any other abnormal findings. Now, let me also present her tumor markers, which was again done outside with she had a CA 125 of 159, and this had been monitored over several years, and it was fluctuating in and around 100 units per ml. And all her other markers at this point in time were normal, including her counts and LFTs and RFTs. Now, the first question that I want to ask is, which radiology report, when we sit on a panel saying does a radiology report answer key questions prior to embarking therapy, I've moderated this as an ovarian mass rather than an ovarian malignancy. Now, the first key question is, which radiology report are we talking about? Is ultrasound good enough? And how good is it if so? May I ask Professor Amita to please answer this question as a gynecologist?
Yeah, I meing, firstly, is ultrasound good enough? The answer is yes. Ultrasound is very good in stratifying the risk of cancer. But ultrasound report needs to have all the essential components. There are several components that are missing in the information that is given to us currently. So we would like to know what is the outer surface of the mass. It's not enough to say whether it's cystic with the solid area. We would like to know whether is it a unilocular, multilocular. If there is actually a solid component, we would like to know its size and what is its morphology. Does it have irregular surface? And we also want to know the vascularity within the solid component. All these things has a bearing in deciding what to do next. But as far as the size is concerned, it's concerning. It's 15 centimeters. It's over 10 centimeter in size. Straight away, that finding puts this lesion as URADS 3 and above. So if depending on the vascularity of the solid component and the other morphological features of the ovarian mass, this lesion could go into a 4 or a 5 category. So, and ultrasound could have been a very good method of deciding whether this patient needs anything further or can this patient be followed.
So I think the biggest takeaway that we had from Dr. Rupa's talk is that the last slide on her presentation, where she said we have to stop reporting cysts as complex, because that is a redundant word now. And I think unless we standardize reports and start using reporting rules, the wide variety of ultrasound reports we get right now makes this semi-reliable, I would say. Dr. Amita, would you like to please add on this? Would you proceed with this?
Yeah, hi, thank you, Ambu. So I agree what Dr. Anuradha mentioned. And I think the biggest problem, although ultrasound is an excellent imaging modality, the problem is subjectivity and the quality of sonologist who is reporting. So often important things are not available, also not in this case, but otherwise many times transvaginal is not done, and a busy gynecologist may not even bother to look whether it was only transabdominal or transvaginal. So essentially it's a very good tool, but provided the person performing does it well and also report all important parameters what are required.
Absolutely agree. So real world situation is that we're getting a very heterogeneous mix of ultrasound reports, and that really needs to change from the side of the radiologists, I think, and as well as gynecologists who perform ultrasounds, because there are a lot of gynecologists who do this. I don't need to go through these busy slides. This has already been covered in the ORATS talk given earlier. And we know that, are these scoring systems validated in our populations? Are we just translating this data from the Western population? Has it been validated? Yes, I think there's a lot of validity, and I think this is now the future that we are looking at. And I think it's important that we start incorporating this into our practice. So Dr. Amita, will you just proceed with this ultrasound report? Will you go ahead and operate if she presented to your OPD?
Probably not. I would
Okay.
know. So I would ask for either a MRI or a contrast CT for this patient.
Okay, so which one? Which one in this particular patient?
Maybe
how do we
MRI.
decide what imaging to order in such sort of a case?
Right. So my choice, maybe if I think in this particular case, if there is a 2.4 centimeter solid area, probably I'm planning open surgery. I would be happy with contrast enhanced CT scan, because essentially I want to know more about extra ovarian things, considering her CA125 is also high. But if I'm suspecting something like endometriosis or any other benign pathology, my preference would be a MRI pelvis with screening abdomen. So that's how we do in practice. So it depends on your clinical plan and clinical suspicion. So, and what I want to know more, is the area of interest is ovarian pathology, then MRI. But if I'm looking for extra ovarian disease, then a CECT will be the preferred modality.
Great.
Because she's a
for a second round of ultrasound, because I see that in many places as well, that they would send to a specialist ultrasound, an expert ultrasonologist. Would that make any difference?
Practically, no. By and large, we don't do this. No.
Especially because it's probably a larger cyst. And Anuradha, would you agree that anything more than 10 centimeters, it's good to have 3D imaging if you're not really sure about solid areas and so on?
Anbu, you need to be a little louder, please.
So is there any
I-
role for sending this for a second specialist ultrasound or an expert ultrasound?
Yeah, I mean, if there is I mean, the literature says that pattern-based pattern recognition by an expert radiologist can give a very accurate prediction of risk of malignancy in the lesion and is superior to IOTA and at scores. But then that is only practical if there is packs and the images are available and we can quickly review the images. The images can be quickly reviewed by expert radiologists, and that is what will make it practical. Otherwise, in real life, if kind of practices we have in our countries, it will be difficult, I think. I agree with Dr. Amita's suggestion that it would be CT or MRI and all the clinical considerations and what the surgical plan is what will dictate the next modality for this patient.
Got it. So now, since we're talking about experience of ultrasonologists and radiologists performing specialist ultrasonography, I looked at this evidence from the current ESCO guideline, which says that, even when you're doing an MRI, you again need to have an experienced radiologist. And with IOTA coming in now, would the IOTA model be have a higher specificity compared to MRI? And with MRI, you need to add certain techniques for it to be reliable as well, right? So what is your take on that? Are we oversimplifying MRI by just sending patients off to MRI? Are all MRI reports made equal? How does a gynecologist sitting with an MRI report decide that this MRI report is done well? How do we assess that? I mean, I'm in an institution, Rupa is my radiologist, so I don't have any concerns about the quality of reports that I get. But if you are practicing in a smaller setup, you end up thinking, okay, I'm going to send to the nearest MRI center. How do I, as a gynecologist, sit with a report in front of me and assess, looking at just the report, that this one is adequate? Could you run me through a few quick tips to decide if this report is all right?
Yeah, and first of all, can you go back to the previous slide and that paper which the one before that, this paper which talks about the next slide, that talks about higher specificity of IOTA compared to MRI. They had actually taken it's a Japanese paper where they'd taken 300 consecutive patients with ovarian masses. And they had subjected all of them to IOTA, LR2 and MRI. So when we do that, then this is the kind of results that we would get, because it negates the benefits of each of these modalities and it compounds the ill effects of both these modalities. So if we do a stepwise fashion, if we do ultrasound first, and then pick up the indeterminate and then subject those indeterminates to MRI, then the value of each modality will come out. So we should not take this statement or the study as an important thing which will determine our practice. That is one thing. Second thing is about how to determine if the MRI is adequate. A few tips would include that MRI that is done should have certain essential sequences, which includes T2 weighted image, T1 and T1 fat suppressed image. T1 fat suppression can either be a chemical shift MRI as well, and the patient should have diffusion weighted imaging, and dynamic contrast enhanced MRI is an essential component of MR-ORADs. So the problem areas in this technique would include diffusion weighted imaging and dynamic contrast enhanced MRI, which is a very unstandardized sequence. Each MRI scanner, they have to standardize these two protocols to get the best results out of it. And that's the most important thing. So if you are continuously engaging with a MR scanner, then we need to have an educational component, continuously engaging with them and telling them that you need all these things to be able to interpret it. You will know that the diffusion weighted imaging is adequate if the high B value images are over 800. That is very important. You would know that the B value that the radiologist has used is enough or good enough only if you have seen complete bladder lumen suppression. The bladder lumen should not remain white in that image. It should be completely dark. Only then you can interpret the diffusion weighted imaging findings. Otherwise, it will be totally not reliable. And dynamic contrast enhanced MRI should start before injecting the contrast, 30 seconds before injecting the contrast, and has to continue for 4 minutes. And none of many radiologists do not have the software to give you the dynamic contrast enhancement time intensity curves. So they will be subjectively interpreting the contrast enhancement of the lesion by comparing it with the myometrium. They will not give you a curve which will be easy to interpret. So you have to insist in the future to give you a curve so that everybody who is dealing with the patient can have that graph to look at and quickly assess the lesion, rather than looking at cross-sectional images and comparing with the myometrium and ovary yourself. It will be much more objective to have that curve in front of you and interpret the graph.
Right. So simply we need to have this conversation going back and forth to get exactly where we want. A quick question, it might sound really ignorant. So if this is not done, if diffusion weighted image is not done, then how reliable is an MRI? Can it still pick up a lesion like endometriosis, or at the other end of the spectrum, can we be happy with the malignancy report?
Yes, MRI still T1 and T2 is helpful in differentiating characterizing certain adnexal masses like fibroids, endometriosis, hemorrhagic cysts, fallopian hydrosalpinx, pyosalpinx. These findings, differentials can be very well said based on just T1 and T2 weighted images. We don't need diffusion weighted images. Diffusion weighted images and dynamic contrast enhanced images come into the picture when we are trying to characterize a solid or a solid cystic adnexal mass. When we want to know whether the solid area seen within the adnexal mass is malignant. So this typically is useful when we are trying to characterize stromal ovarian tumors, benign stromal ovarian tumors from malignant ovarian masses. That is the subset of indeterminate ovarian masses where these two sequences, diffusion weighted images and dynamic contrast enhanced MRI, would play a big role in characterizing these masses.
Thank you. That is a great tip. Considering that the subset of patients who have, say, a fibroma or a thecoma compared to a malignancy, especially in a high volume center, I guess the percentage of patients who will have such sort of benign solid tumors is going to be less, isn't it? So to a large extent, I'm guessing the take-home message is if you have an indeterminate mass, especially if you're thinking, say, endometriosis, or at the other end, if you're thinking of a malignancy, these are the tips that you have to look for, and you have to engage in conversation with your radiologists. And I can't stress enough that MRI is for sonographically indeterminate adnexal masses. Am I right? Can we still stick with ultrasound if we are able to get a clear ORAT score of benign or malignant, and move on to CT scan if it is clearly malignant? What would be your advice on that?
Absolutely, I completely agree. MRI should be a staged investigation. And also coming back to that paper from Japan, which showed, which compared adnexal masses with two modalities, that is not applicable to real life practice. Because in real life practice, the specificity and the accuracy of IOTA itself will vary depending on the practice setting. IOTA, the way it performs in a gynae oncology setup or an academic setup, is totally different when compared to how it will work in the community. So for a modality to be community ready, it has to start with ultrasound. And in the community, the indeterminate masses must be reassessed by with the second look by an expert radiologist or an expert gynae-oncologist who can look at the images and then decide the need for MRI. So that is what will be best for the community. And in oncology setup, yes, only a small subset would be indeterminate. So basic sequences will work very well for characterizing most of the masses. There'll be a handful of them who will need diffusion weighted images and dynamic. So if we have the luxury of having a radiologist monitoring the scan as it's happening, a lot of scope for table time, there's a lot of scope for saving table time, MRI table time, by kind of tailoring each patient's ultrasound MRI scans is possible. But many centers will not have that luxury of having the radiologist continuously monitoring the scan as it's happening on the MRI gantry. So
yeah, the operative word there being luxury. So, so I ordered for an MRI because this was a large mass. In my opinion, I was not happy with an ultrasound done outside, and I didn't go in for a second opinion ultrasound. So an MRI was ordered, and it appeared that she did have a solid area, but this was predominantly an endometriotic cyst on the report. And she was 40 years old. She had undergone multiple lines of medical management, and she was now ready for hysterectomy with a BSO as well because of the the effect of the ovarian hormones on pelvic endometriosis. But this was a curveball because ultimately after the biopsy came out, this was a seromucinous borderline tumor of the right ovary. So I'm going to ask you, where will a borderline tumor fall into your MRI? I think you answered part of it already to Dr. Bhagyalakshmi's question of where does MR help in borderline tumors? How does the ORADS help? Like even if we have a full-fledged report, does it fulfill a borderline tumor? Because I don't see it in your ORADS 3 or 4.
Yeah, borderline tumor will usually come into 4. It may not be, it may or may not be 3 depending on its size. So it will usually, yeah, like projected in the slide, it will be ORADS 3 or 4. And dynamic contrast enhanced MRI typically will not show a type 3 curve in a borderline ovarian mass. Those solid components are not going to have that sharp, intense early enhancement and then retention of contrast equal to the myometrium. They're going to be more slowly enhancing lesions. So they're going to have type 2 or a type 1 curve on dynamic contrast enhanced MRI. So at the maximum, they will end up being a 4.
Okay. So is there any role for the EDNEX model? Because this is literally the only model that I saw which could potentially give us a diagnosis of borderline or at least a risk for borderline in its scoring. How often is it used? I've not seen this being used in any report that I've come across so far. Is it being used here? How reliable is the IOTA EDNEX model? Could you tell us something about this?
Is Rupa taking this question? Yeah, I will.
Anu, you have to take this question.
Okay.
I don't.
Sorry. Okay. Yeah. Basically, IOTA EDNEX model is a very effective tool which can be used by the gynecologist or the gynae-oncologist in their clinical practice. So it has both clinical components and it has some radiology components to it. As long as the description of the imaging findings is accurate, we will be able to use the IOTA EDNEX model in our practice using a calculator that is or a software that is already available on our mobile phones. So it is a very effective tool in my opinion, and the way it is developed is very interesting. It's based on logistic regression analysis of a large cohort, and so it is a very effective tool. Yes.
Okay. So this, I will end this here because we can go on about the different models that we use in radiology to take home some messages, at least from this case. Ultrasound is the first line of imaging for head and neck cell masses. And I believe that the IOTA, the ORAT score should become part of a reporting that could standardize the wide variety of reports that we're getting right now in clinical practice. And if there are indeterminate masses, we go on to MRI. And a potential tool for borderline tumors could be an adnexal model. It comes as an app that you can install on your phone. You feed in data and it gives you a relative risk scoring or AUC for borderline tumors. Now to involve the others on the panel, I'm going off to case 2. This is a classic case presenting to an oncology department, a 60-year-old presenting with abdominal distension, difficulty in breathing, no obvious medical comorbs at presentation. She had an ECOG performance score of 2 and she was mildly orthopnic, no nodes, breast normal, abdomen was grossly distended with ascites, and she had a vague lower abdominal mass. Vaginal exam, her uterus was displaced downwards by a predominantly right adnexal mass and a very nodular POD. Tumor markers were obviously sent, and there was CA 125 of 2000 and odd. There's an obvious question, but I would like Dr. Jaya Ghosh to please answer this question, because most of these cases, I believe, come to the medical oncologist, at least in my setup. For some reason, they end up going to the medical oncologist. So what imaging would you order and why, and what will you look for? How do you decide when to send this patient to a gynae oncologist?
Thank you, Dr. Sonal. So for this patient, like she has gross ascites and suspected, I mean, she's orthopnic as well. So I would order a CT scan, a contrast enhanced CT scan of the thorax, abdomen, and pelvis in this patient, because I would want to know what is the extent of disease. And sorry, you have asked this question of thorax. So I mean, the basic minimum is we would do a CT abdomen and pelvis, and if and at least a chest X-ray. But if we have a suspicion of effusion, then I would definitely go ahead and do a CT thorax as well. So that is there. And of course, followed by that, we would do a cytic fluid cytology and cell block.
Yeah. Would a gynae oncologist be involved at this point itself?
Yes, we do. Like all these patients would definitely.
So, let me tell you. So, by and large, practically at Tata Memorial Hospital, all new cases are seen by gynec oncologist, and we have this joint clinic happening. Yeah. So we have but multidisciplinary team approach, and every patient is attended by these MTTs, and decisions are taken in these meetings. But
yeah, I wouldn't take a decision to give chemotherapy without consulting our gynec.
Okay, that's the biggest driving home point for me, that please involve gynae oncologists. I'll end there. It's as short and as succinct as I can be. Now, we know that NACT or neoadjuvant chemotherapy is a large chunk of these patients with stage 3 ovarian cancer, which I'm assuming she is, will go in for neoadjuvant chemotherapy. Of course, we assess them clinically, and if they're high perioperative risk, they go in for neoadjuvant chemo. And if they have a low likelihood of achieving cytoreduction, they go in for chemo. How do we decide this? How do we decide, Dr. Amita, how do you decide in your practice on whether this goes in for chemo or whether this patient goes into the surgery setting?
okay. So, we need to consider multiple factors of what we do. We consider multiple factors, including patient factors, radiological, disease factors we have already heard at length. But what is also important, patient-related factors like age, any comorbidities, a recent history of MI or uncontrolled diabetes or, DVT, or patient albumin. All of these are also important. And of course, disease related factors you just mentioned, whenever there is less likely possibility of achieving less than a centimeter or optimal cytoreduction, stage 4 disease,
patient with poor performance status. And also one important factor which we need to consider in our kind of patients is patient's financial status, because we know that upfront aggressive cytoreductive surgeries, the ICU stay, the need for higher antibiotics, parenteral nutrition and other things is very, very high. And many times you may do aggressive surgery, but next day you may find that patient doesn't have money to manage all other things. So that's also we need to take into consideration. So these are some things we would consider while deciding between upfront surgery versus neoadjuvant chemotherapy.
Okay. Absolutely. I think this talks about the real world scenario. This is basically how it is in most centers across India, and I'm sure it is in Bangladesh as well. Finances come into play a huge role in decision making. But considering this is a panel on how we best utilize the CT, what are the CT parameters you look for? Could you take me through a good, suppose I gave you this picture, would you take me through a quick roundup of which areas do you focus on, do you look at when you straight away send the patient off to neoadjuvant?
I think Anuradha very nicely mentioned all of this. And Palak, are you there? So again, as I said, we do joint clinics for all our patients. So some of the areas you have already mentioned, like bulky diaphragmatic disease, extensive retroperitoneal lymph nodes, especially extending supra-renal, peritoneal carcinomatosis, disease at root mesentery. I mean, splenic high lump per se is not a contraindication, but if it's associated with other things, if there is this extensive extra abdominal disease, like if there is extensive mediastinal adenopathy, supraclav nodes, or pleural disease, which we can see, pleural effusion per se may not be, but pleural nodules, or pulmonary metastasis. These are some of the contraindications or indications for neoadjuvant chemotherapy.
Agreed. So I think I thought this was a great chart to put up on your say a desk or something like that for early career oncologists or for students who may be attending today, because the pink boxes basically all the boxes, the yellow highlighted ones are the ones that are hard to resect, and it can help us to go through a quick checklist. But I think the major decision making point is the patient factors, as much as a CT would probably contribute about 1/3 of the decision-making process, I think. So how does this compare with laparoscopy, Dr. Amita? I mean, we are talking about PCI on CT, we are relying so much on CT to decide, but in an apex center like Tata Memorial, where you must be doing staging laparoscopies, how does it compare with laparoscopy? Is it really that reliable? Are we likely to miss out?
Yeah, we do not do laparoscopies often. Our decision is essentially based on pre-operative imaging. So to be honest, I have very limited experience with diagnostic scopies in advanced cases. We rarely do this. So I really am not the right person. Maybe Dr. Rupinder or Bhagya or Jeeta, if they are using this. Personally, I have very limited experience with diagnostic laparoscopy. But my concern is also, laparoscopy we may not assess may not be able to assess all sites on diagnostic laparoscopy. So, but personally, I have very limited experience.
Okay. Quick question to Anu. Can R0 be predicted? Are there PCI scores to predict surgical outcome? Is it reliable? How does CT scan help for predicting R0, Dr. Anuradha?
Yeah. So this paper, the radiological assessment of PCI and ovarian cancer, so that this is the 2020 paper. So it says that it contradicted the previous other publications in this area. The first paper by Paul Sugarbaker, he had said that PCI actually predicts cytoreductive surgery, but does not predict survival outcome. That was his results. But this paper says completely opposite finding. It says it does not predict outcomes of cytoreductive surgery, but predicts survival. So, yeah, so the literature available currently are very mixed in this area. But in general, CT underestimates PCI. But in ovarian cancer with an extensive disease, underestimation is not the issue here. The issue is to be able to decide whether the areas that are seen on imaging, are there any areas that would prevent achieving complete cytoreduction, because the final outcome that we want to achieve is complete cytoreduction. So we should consider imaging not based on its accuracy or compare CT with laparoscopy or CT with other things or with other models. We need to use CT for its strength, which is looking for unfavorable sites that will prevent completeness of cytoreduction. So I think that is how we need to approach. And our own experience says that we've looked at the primary cytoreduction cohort separately. The CT really predicts outcomes of primary cytoreduction, but it has not been so good in the small cohort we've had on the post-neoadjuvant setting.
Got it.
We still, now we've just started the prospective trial. So hopefully in a couple of years, we will have that results. The retrospective study, you can see our paper by the end of this year, I hope.
Great. Really looking forward to that. Hoping that.
So how often, if I may ask, Anuradha, at your center, you use diagnostic laparoscopy?
We don't use, Dr. Amita, just like yours, we don't use diagnostic laparoscopy for ovarian cancer. I've seen the colorectal surgeons do a diagnostic lab for CPMs, the colorectal peritoneal metastasis. But I've not seen gynae oncologists do laparoscopy to assess the extent of it.
I think the only thing which CT can miss and picked up by diagnostic lab is peritoneal carcinomatosis or a small bowel.
Biliary metastasis.
Biliary metastasis.
And I think you can never kind of only stick to laparoscopy or only CT to be very sure. I think both are complementary, as you rightly said. Adhesions in the bowel are very common, and laparoscopy will be incomplete in a setting of adhesions. We see that often. That's what the colorectal surgeons tell us, that it was an incomplete laparoscopy because of adhesions, and they will come back and ask us, was there disease in these sites?
Yeah, so like areas like lesser sec, retroperitoneum, and many areas are very difficult to assess on diagnostic laparoscopy. Yes. And the other concern, of course, is delay in if CT definitely suggesting advanced disease, delay in starting definitive treatment in the form of chemotherapy, another anesthesia, and all of that logistical things. So
absolutely.
Very true. So I think it's truly, it takes a lesser role as far as our setup is concerned, because there's cost implications as well. And it's not as clear cut as we think, that go in and we see all of the disease spread out before us. I think laparoscopy also, in the few cases that I have done, I've struggled to actually go beyond a very thick commental cake and trying to assess what's lying behind it. And I think it's truly complementary with CT scan. So right now, I think we'll stick with CT and hoping your scoring system comes out at the end of the year or maybe in a couple of years. So when can MRI add value? I mean, do we have to add an MRI component where when we're looking at, say, a rectosigmoid infiltration by the tumor, will it help in planning bowel resection, or is CT good enough? Because I've seen sometimes can you add to that?
We don't do MRI in our practice for ovarian cancer staging because the counseling of the patient for colostomy does not really depend on what we find on MRI. So if we already say that there is a lost plane on CT, they might as well go and consent for colostomy. They might as well have the other colleagues who need to be present for the surgery and block their time for assisting the particular cytoreductive surgery. So that is how it would work in our center. So we have not seen added value in adding MRI to CT scan.
Got it.
Yeah, I agree with Dr. Anuradha, and at our center also we don't by and large. And if there are serious concerns about bladder bowel infiltration, we would rather go for a colonoscopy, and just be little sure if mucosa is infiltrated or not.
What about PET CT? Do we need PET CTs at all? Do you have a small subset of patients where you look at if PET CT is necessary? Maybe visceral metastasis or extra or retroperitoneal lymph nodes where you're not sure about. Is it going to make any difference at all in patient management?
Yeah.
Tamita?
Practically, we rarely use PET CT. So I'm not so sure in a frontline management. Recurrent settings, maybe sometimes, occasionally I do use, especially before planning secondary cytoreductive surgery. But frontline,
not in the upfront setting. Got it. So, so this patient goes off to finish her chemotherapy. Post chemotherapy. Now, this is I don't think there's much evidence in what do you do after your 3 or 4 cycles of chemotherapy? Do you compulsorily do a CT scan, or is an ultrasound enough prior to laparotomy? Do we just do CA-125 monitoring and a clinical assessment? What are the pros and cons, Dr. Amita? How do you decide what imaging after the patient's neoadjuvant chemotherapy is done?
So we do clinical assessment. We do CA-125 assessment on whichever tumor marker was elevated. And we also do CT scan for response assessment. But, since you have put ultrasound, I'm just thinking whether we should, but practically we never do a sonography prior to surgery. We always do assessment, response assessment, pre and post chemotherapy by CT scan.
So now, by doing CT, and if you find that the disease, would you have any parameters based on which you would give them more cycles of chemotherapy, or is it anyway going to be surgical? Then if so, why would you want to do a CT scan at that point? Why? I'm just being the devil's advocate here. Why not just an ultrasound?
Right. So, it will be clinical and serology if there is CA-125 response is poor. If clinically we still feel there is extensive disease, many times you can feel mental cake, ascites, and fixed pelvic masses, all of that post chemotherapy, if that is there. And if CT scan shows poor response to disease which was there prior to chemotherapy, especially diaphragmatic disease, retroperitoneal lymph nodes, and mesenteric disease. So these would be the cases. One, here we have to be very sure that we are dealing with ovarian cancer. So if, as Dr. Jaya mentioned, we do cytology and we do cell blocks with immunohistochemistry on cytology fluid, on blocks for all cases. Our sensitivity is quite good, but in this particular case, situation, if there is poor response to neoadjuvant chemotherapy, we go back and discuss with pathologist, and if required, they may take a biopsy at this point to rule out either a low-grade tumor. So that's one thing we have to remember, because these low-grade won't respond that well to chemotherapy, or any other metastasis from some other. So may do a biopsy after chemotherapy if there is poor response. And if biopsy confirms high-grade serous kind of tumor or high-grade ovarian primary, we would give, depending upon response to 3 courses, either we continue more of same chemotherapy, or if there is very poor response, they may decide to give another kind of chemotherapy. If it's low-grade tumor on biopsy, then, despite having rather extensive disease, we may decide to go in and do surgery. So that will be one situation where we do surgery with poor response, despite having not so good response.
Got it. So CT scan after, Dr. Jay, do you have something to add? Please go on.
No. So I just wanted to just add on to what Dr. Amita said, and a very clinical correlate is for those low grade is that, if the patient is looking fine, and the CT scan is looking very bad, and we might have very poor response on CT, but patient is still ECOG 1 in a young patient. Those are the patients, we do go back and ask our pathologist, please look for whether it's a low-grade tumor. So that's the only thing.
Okay. So it is CT scan after neoadjuvant chemo, and it can help us pick out these rare types like low-grade serous or maybe a metastatic disease if poor response is found. Let's assume that she's completed treatment. What is the current consensus on post-treatment imaging surveillance? Like once she's completed treatment and she comes back for follow-up every 3 months or every 6 months in the following years, what is the consensus on imaging?
So of course, clinical history and examination are important component. We do serum tumor markers, but we do not always do imaging. Imaging by and large is done either patient, many times they come with outside imaging, or if patient is symptomatic, or on examination if we find some abnormality. So routine imaging by and large not done.
Not done. Okay, no ultrasounds, no CT scans. Obviously, no CT scans, too much radiation. Once a year CT scan, once a year PET CT, I see that quite often.
So you will see even like every 3 months patients do undergo PET CT. I mean, that's different, but by and large, we don't do unless patient is symptomatic. And if cases where we may do are cases where tumor markers suppose initially not elevated. So when we know tumor markers are not reliable thing for follow-up, there we may do, but generally we don't do. We follow up with tumor markers.
Yes, and this the FIGO Cancer Report 2021 also mentions this in post-treatment surveillance, that there is no imaging modality that needs to be done when the patient comes for routine follow-up, and if clinically and biochemically, if everything is normal, no imaging modality is actually advocated. It is done based on symptoms, based on maybe rise in tumor markers which were elevated prior, and this comes out of the FIGO Cancer Report. To finally have Dr. Supriya be involved in this panel, the only time I think of a radiation oncologist, obviously CA ovary is a disease for the surgeon and involves the medical oncologist mainly. But the only time I actually think of a radiation oncologist is in a setup like this. So let me have Dr. Supriya please come in, and if I have an ovarian malignancy with peritoneal mets and a bleeding vault recurrence, can RT help? Can you tell us how it can help? What is the role of the new kid on the block? I mean, stereotactic radiotherapy. Dr. Supriya, please.
So let me put it this way, that in our center, we are essentially using radiotherapy for patients who are platinum refractory when it comes to treating patients who have advanced or they have recurrent disease. So that is one major indication, and such patients, they could have disease either in the vaginal apex, or they could have nodal disease, or they could have a more diffuse peritoneal disease. So patients who have peritoneal disease, though a lot has been written in the literature for patients who have at least more than 1 to 2 centimeter disease about whole abdominal radiotherapy, but over the years, the use of whole abdominal radiotherapy has reduced because the therapeutic ratio that you get with whole abdominal radiotherapy is not very lucrative. So what we tend to do for most of the patients is that if they are platinum refractory, and if I get a referral for small focal lesions, then we take them up to radical doses of radiation. It is not only done for symptomatic or symptom control. Why? Because if patient has indeed become platinum refractory, even though there are multiple chemotherapy further line options, either they are not accessible or they are not going to work. So this is what we do. And as far as stereotactic radiotherapy is concerned, it is generally used for metastasis. And if we
something like this?
Yes. So here I can see that it's also done for the node, but we have nodal lesions. I tend to fractionate more, knowing that down the lane patient may receive bevacizumab or any kind of anti-VEGF therapy, and try to keep it
very safe for the GI structures is also one of the responsibilities, because primarily these patients will develop also because of their disease GI complications. So these are the classical indications, and typically we would treat 28 to 30 patients per year with radiotherapy in our center, either for platinum refractory or metastasis in a year.
So when you're talking about platinum refractory ovarian cancer in the upfront setting, is this whole abdomen radiation at a lower dose than is usually given? Is that what you're talking about, Dr. Supriya?
So, even in the so let's separate out about, platinum refractory and whole abdominal, because whole abdominal radiotherapy, if you just talk of evidence, it also works in platinum sensitive cohort. So if you look into 2005 to 2010 studies from Princess Margaret, they are actually very, very good studies for patients who are stage 3, stage 4, who have undergone optimal cytoreduction, completed platinum-based chemotherapy. And if you add whole abdominal radiotherapy, there is survival benefit in stage 3, 4. And this benefit is even more pronounced if patient has, a different histology, clear cell or otherwise. But, how patients actually get referred in the clinic, they don't get referred in the adjuvant setting. They get referred when they have failed multiple lines of chemotherapy. They have no bone marrow reserves. And when you add whole abdominal radiotherapy, then all of them develop toxicity. So the general impression goes that it's a very toxic treatment. So doses that are used, of course, you cannot use very, very high doses, but with IMRT, people have gone up to 40 to 45 gray while sparing most of the normal structures. Having said that, broader experience outside clinical trials is very limited. So I think the win-win situation is, so what is the aim? In adjuvant setting, the reality is that no one is using whole abdominal radiotherapy. So the idea is to maximize, patient tumor control when they become platinum refractory. And there are at least 20 to 25% patients with advanced tumors who would become platinum refractory. And the other thing is that traditionally ovarian cancer is thought to be radio resistant, but I just want to, take back that before platinum era, all patients used to be
considered radio sensitive, isn't it?
It is radio sensitive, like all other adenocarcinomas. Prostate cancer gets cured with radiation, adeno, medically inoperable endometrial cancer, breast cancer. So the sensitivity is as much. So I think early referrals is the key when chemotherapy is not working.
Just to add, maybe, histology plays an important role here when we talk about radiation. Maybe endometrioid histology or clear cell or mucinous pelvic recurrences. These are the cases where I think radiation has some role to play.
Actually, it is the other way around. Actually, it is the other way around. I would just say it's the other way around. Chemotherapy doesn't work in these histologies. Radiotherapy works in these histologies. So the consideration is actually the other way around, that for, when you have clear cell, possibly that should be considered.
Yeah. So because these tumors, one, they are not so chemosensitive, and second, they are generally at relapse confined to pelvis. So unlike serous histology, where you will see disease everywhere, more disseminated recurrences, and they are more sensitive to chemotherapy.
Yeah, just adding on to that, the ones that we do refer to the radiation oncologists are not the ones where you have extensive peritoneal disease. These are the ones which, as was rightly mentioned in the case, limited pelvic recurrences. And we see that, they keep recurring at the same time, at the same place, even after repeated courses. So those are the areas where we do consider them for, do refer them for radiation.
Another last quick question, Dr. Supriya. So if the patient has been given a second line or a third line chemotherapy for a wall recurrence, can radiotherapy be given quickly after to follow up, kind of like a chemo radiotherapy protocol?
So basically it all depends, so for ovarian cancers, I'm not going to treat broader pelvis. For example, lymph nodes, if patient has already undergone a surgery. So this question comes because patient's marrow is already gone with multiple cycles of chemo. When you add pelvic radiotherapy, which has a lot of marrow reserve and already marrow is hit, so can you add it quickly? So typically we would wait at least 2 to 3 weeks after the last cycle of chemo, but normally that doesn't happen because for the clinician to come to a decision that patient is chemo-refractory, 6 to 8 weeks are anyway lost before patients are referred to us. But technically, we can position 3 weeks after last chemotherapy, but in real world, these patients will come 6 to 8 weeks later because they are undergoing assessments and decision processes.
Got it. Got it. So with that, we will conclude this panel. I hope we've had a bird's eye view of how we could use imaging in different scenarios. And I hope you had some key take-home messages. Thank you so much to the panel, Team Tata, Bangladesh Oncology Society, and to the audience as well. Thank you.
Thank you, Ambu, for an excellent discussion. Thank you.
Thank you very much.